Every time I got one down, they guys like. Let's do it. Thank you. That's amazing.
Okay, I'm gonna go ahead and get started because we do have people on the line that are waiting for us to start at 2 o'clock. So I figured if I just start talking. Into the session. One of the things that I want to cover today is, how do I? First of all, if you haven't signed in yet, if you can, please sign in. This helps us make sure that you're in our database and also send you the CME instructions. And for those of you online, by signing into the Zoom webinar, that is considered your assignment. The other item to scan is the pre-test. This is also on the website, so and please go ahead and scan this QR code and complete the pre-test online. This is for CME. Here's our faculty lineup. You know our series chair, Dr. Stefania, for session. Definitely, four faculty presented.
I know where you're going.
Third agenda, this is in your guidebook, if you handed out. Registration. And then this is a webinar. So I'm at mic right now, they can hear everyone. So as we get rolling, we'll want to kind of quiet down and stay here in the whole room. And so if you ask a question, you'll be able to be heard no matter where you're standing, as long as you're not too far back there, I guess. So you're gonna be like from this side of the asking person. Probably. And that is all I have for you guys. And now we're gonna go ahead and introduce Stefania. You wanna?
Thank you.
Okay.
So I'm Dr. Maraka, one of the neuro-oncologists here at USC. So we are in the session today. Just for the people in the back, we're just starting, so it's a little bit acoustic room. So for any talks or of the presentations, it's be on the back room so that I cannot hear the speakers. So thank you for all coming today. Really exciting. We did our summer CME series, and now we're in the winter, as you can see. It will be a very interesting day with a lot of talks, maybe with different topics in general oncology. And there are 2 more days into our winter series from next week too. So stay tuned for that. We're gonna start today with Dr. Daher. He's our neuro-oncologist at University of Illinois at Chicago. He specializes in primary brain tumors, along with brain mets and endometrial disease. We are very fortunate that he launched our basic science program at UIC, and his research is focusing on finding blood biomarkers and understanding more the tumor heterogeneity. So we're gonna be able to find better treatments for glioblastoma patients. So he's gonna talk to us today for the classification of gliomas that keep changing and how that affects the treatments for these patients. So with no further ado.
Right. Good afternoon, everyone. I'm Ahmed Daher. I'm neuro-oncology at UIC, as Dr. introduced me. And the title of the talk today is the molecular era in glioma management. I skipped my financial disclosures, which have taken 20 slides, but I have not. So the outline will briefly go over some introductory slides, like any talk about brain tumors with emphasis on the gliomas, and then talk about the transition in the diagnostic criteria over time between morphologically driven to molecularly integrated, and talk about some practical implications of that in practice that we deal with, as well as some future perspectives. So as some of you may know, the focus will be on the primary brain tumors more than the mets. There's more than 120 distinct primary brain tumors. Majority of them are benign. Roughly ratio is 2:1. And the incidence in the US is about 94,000 cases per year. The mets, they outnumber them by a ratio of 10:1, so close to 1 million. But that's not what we're talking about. These are data from the Central Brain Tumor Registry in the US, which collects data on incidence and various features in 5-year increments. So this was published last year. There's a 2-year lag. So this is the 2018 to 2022 most recent data. It shows that in adults, the incidence is quite low, like on the lower end of the spectrum amongst other malignancies. But in the younger adults and in the pediatric population, you start to see the incidence outranking other tumors. In terms of distribution, like you see blue, mostly non-malignant. Meningioma occupies the biggest portion of the pie chart. About 40% of all primary tubular meningiomas. And glioblastoma, see that in red, is one of the most common malignant ones. The section A is just talking about distribution within the brain. So it's mostly lobar, frontal, parietal, less so in the brainstem and posterior fossa in the spinal cord. And slide B is within the malignant primary tumors, you see GBM is almost half them are these really malignant ones. In terms of female to male distribution, most of them are male predominant, but not by a lot, like there's 1.1 to 1.5. The exceptions being meningioma, more common in females, or like germ cell tumors, a lot more common in males, not just by. But for the most part, it's fairly equal distribution. The geographic features, so these are the lower grade gliomas, the oligozygotic asteroids. They're mostly characterized by these clear hyperintense, non-enhancing, they don't pick up the complex type, with exceptions, of course. There's no clear differentiation at the MRI level between an oligo and an astrocytoma, for example. But once they start to enhance and have more sort of mass effect, those are the higher graded. They enhance because the peripherally administered contrast seems through the blood-brain barrier. That means there's an aggressive process behind it, such as a high-grade glioma or a brain. Cystic heterogeneous enhancing, some of them can have two foci of disease. You see in the picture over here. The main lesion, there's another focus of disease. So they could have more than one focus, but a lot of times it's just one lesion. And sometimes it's not enhancing, but really aggressive looking and different sizes, different lesions. So pathologically, if you read the pathology report to grade these tumors, it starts by talking about, oh, this is a hypercellular tumor, there's marked atypia, which is shared amongst all malignancies. But as you start commenting more on the mitotic figures in the pathology slide, that escalates the diagnosis to a grade 3. And if you have proliferation and or necrosis, that's a grade 4. So that's how continue to use the same criteria. The pictures at the bottom shows the oligonucleoma on the far right, the middle is an astrocytoma, and on the far left is the glioblastoma, which shows the necrosis in the middle. Molecular criteria is being integrated in practice, and we'll talk more about them, but they could be both at the level of just staining with antibodies for certain relevant markers. GFAP is a glial marker, IDH is a relevant mutation, and PCR studies as well to look for more DNA mutations, MGMT, and I'll talk about the significance of those. So that's the basic introduction. History-wise, why did we go from morphology to the molecular sort of entities? This is from a 2009 published study where they collected from the Cancer Genome Atlas a lot of GBM samples and then did multi-omic profiling on them, different molecular platforms, DNA, RNA, etc., microRNA, copy number variations, and they lumped them into 4 molecular subtypes: neural, classical, mesenchymal, each with a certain sort of molecular marker. But why is that? Was it just we now know more molecular, so let's try to understand them at that level? Not everything we rename or we do doesn't necessarily just done for academic curiosity. The example I give, which is not sort of very analogous, but when I was in training, we used to call seizure medications AEDs, antiepileptic drugs. Now they call them ASMs, anti-seizure medications, and that change from AED to ASM saved countless lives. No, not really. But this is why this is relevant, and this is at the pathway level. 3 main pathways in glioblastoma: the receptor tyrosine kinase pathway, EGFR driven, or surface tyrosine kinase with downstream signaling, or the MDM p53 pathway, or the CDK-RB pathway. You rarely find a glioblastoma that doesn't have alteration in one of these 3 main pathways. So this is why it's relevant. This is a Kaplan-Meier curve analysis of different molecular types of gliomas. And what I want you to focus on is the red and the blue. So of course, the glioblastoma IDH wild type has the worst survival. The purple and greenish are the lower grade ones with good molecular markers. What you can see here is red is a lower grade glioma, but does not have the IDH mutation. And the blue is a GBM, or what we used to call GBM, because histologically it had the grade 4 criteria, but it had the IDH mutation. This is an example where we see the presence of a positive prognostic marker like IDH mutation superseded the histology. The lower grade did worse than the higher grade, and the distinction was based on the IDH mutation, which without it, even a low-grade tumor would behave very badly. So these are some of them. I'm not going to mention every single observation that help or got incorporated into the new diagnostic criteria, but these are some such relevant, clinically relevant information. Methylation playing largely a role, and I'll talk a bit more about it later, but this is from a 2016 published paper in Cell, which showed amongst these gliomas, amongst those bad IDH wild types, there's a subset of them, even though they have the bad IDH, lack of IDH mutation, they behave positively. They had much better survival than IDH2. Conversely, amongst the good IDH mutant ones, there's a subset in green that behaved poorly. And those could only be picked out by methylation profiling, not by another platform. So there's relevance to, even within a good sort of tumor population, you can have subsets of poorly and better acting ones. And the choice of profile can help you distinguish that. In some cases, methylation picks them up, in other cases, other type of signals. And MGMT prone to methylation, we hear about a lot in the GBM. MGMT is a DNA repair enzyme. So in tumors, it can be upregulated to combat, to help repair the DNA fast for the tumors that can keep dividing and growing. Cancer therapies that affect DNA damage, like alkylating chemotherapy, like radiation, they are, if the DNA repair enzyme level is high, they are less effective. So we can see that here in this survival. Those who had, and we tested at the level of the promoter. The rated promoter means low level of the enzyme. Those who were methylated did better than those who were unmethylated, meaning those with low level of the enzyme did better than those with the high level of the enzyme, suggesting an important prognostic feature of this. And it's also predictive. So in relation to certain DNA damaging therapies like radiation and temozolomide, you see the same thing. Those who have low level in orange of the enzyme, like a lot better than those who have high level of them. Whether they did radiation chemo or just chemo. This now makes its way into our practice, whereby clinical trials for GBM are no longer just any GBM. Many times, not always, they're separated. This is a methylated GBM or unmethylated GBM. They prefer trial sort of recruitment, so that we don't dilute the patient population with a large percentage of negative prognostic. This table summarizes the change over time. As you all know, 1979 was the first edition of the WHO. 2021 is the most recently updated edition. And then over time, without going into every single box here, it moved from histology to some immuno to some more genetics to some further knowledge. And in 2021, it became an integrated diagnosis where we didn't get rid of histology, but molecular is part of the diagnosis. And this summarizes, the impact where it was none to minimal to supportive, actual required. And then some of the key concepts with each addition, from just giving them some name, validating them, or entities to molecular fixed. With regard to the glioma, which is the emphasis of the talk today, the low grade and GBM, what changed in the current edition is it became more discrete entities. What does that mean? We used to call it astrocytoma, oligoastrocytoma, or astro with oligo features. That terminology is no longer there and didn't prove to be of any relevance. They're discrete entities now. And then GBM, it used to be any grade 4 is a GBM, so histologically driven. Now it's molecularly driven. So regardless of the previously mentioned histological criteria that upgrades the diagnosis to grade 4 or not, it's about the IDH mutation. If you haven't, even if you have all the necrosis, whatever, you're just a grade 4 IDH mutant astrocytoma, you're not GBM. If you don't have IDH mutation, that's IDH wild type. Even if histologically it had very few mitotic figures or no necrosis or fertilization, it's a GBM. So GBM became a molecular disease, not just histological disease. And in summary, so over time, we went from histology-based to histology dominant by the year of 2021. And I suspect it's going to be many years before more changes will be integrated, but the work is still ongoing. All right. So it's not just about, okay, we changed the name nomenclature and why it was important to do so. How is that impacting us in our practice or in our research? So I'm going to mention 3 different examples here. The first is from a study I did a couple of years ago, or finished it a year or 2 ago, started a few years before. comparing long-term survivals to short-term survivals in GBM. So that's the LTS versus STS, 15 versus 20. And you could see that really the survival was quite markedly different between them, 59 months to 9 months. GBM average, when you look at clinical data, survival is in the 14, 16 month range. So what I wanted to see is there something in the tissue that could have predicted why there's such a discrepancy? These are patients I myself was involved in their care, so I knew the survival was not impacted by non-treatment related things. So all of these patients got treated the same way, radiation, chemotherapy, survival was not impacted by heart attack or someone never started. And the survivals, the long-term survival had a lot more of the MGMT promoted methylation. So I did a couple of platforms, but the one I'm going to mention here is the microRNA. They were sequenced, and the microRNA was analyzed, and differential expression studies were done, and it showed in the long-term versus short-term population about 43 differentially expressed, statistically significant differentially expressed microRNAs, indicated by the red dots. Within the methylated population, because I wanted to focus not just on seeing a bystander effect of MGMT methylation, which we know improves survival, within the methylated also, short-term versus long-term, there was 35 differentially expressed microRNAs. Now, these are bulk sequencing. So to prove that these are relevant, one has to target PCR, because we don't want the result to be biased by one case that had 10 billion copies of one microRNA, making the group appear as a small amplitude. So that targeted PCR shrunk the list from 45 to 4 within the overall population that are relevant, because they were target PCR. Every single case of aggregate is down-regulated, maintained the same differential expression, and 4 within the MGMT. Two of those were shared, and 2 were unique. So this is an example that showed us molecularly this can be a way to look into the function of these microRNAs, what pathways are involved that may impact survival regardless of therapy, and may open the avenue for, if we identify certain genes or pathways that these microRNAs control, it will open up avenue for treatments in a molecular driven fashion. This next example is about liquid biopsy. We have a lot in systemic malignancy in the brain cancer world. It's still in its infancy, even though people have been talking about it for at least a decade by now. So this is from research I'm doing right now. This is 12 GBM cases versus 8 healthy controls who had clean MRI and no systemic malignancy. And the plasma was analyzed to look for any differential expression in the microRNA on the left, and 6 such differential expressions were seen. And on the right, mRNA, transcriptomics, and 766 hits were found. The next step of the project is to further validate this similarly to the previous project by doing targeted sequencing for these markers. That is ongoing. Now, that's just something just to give you an idea of what we could do with better understanding of molecular makeup of the tumor at the level of diagnosis. And I'm going to mention a case that I saw recently, a few months ago. This gentleman in his 40s presented with some dizziness and then balance problems for a few weeks. And the MRI showed this large, expansile, very intense lesion in the brainstem. You can see it here, it's got the pons and the medulla. Now, the next step usually is to diagnosis to get a biopsy. In the brainstem, those options are much, much more risky. So what are the possibilities here? Just looking at it radiographically, midline glioma, which is a separate entity now in the 2021 diagnostic criteria, molecularly defined, is high on the differential because these present in the middle of the sort of the brain. An IDH mutant astrocytoma is on the differential always, and even an IDH wild type, so GBM. Now, treatment first time is going to be the same, so it's not going to matter much. You're going to get radiation chemotherapy regardless of the molecular makeup. But on recurrence or second line, if this was a midline glioma, it has an FDA-approved drug now as of last year, because these tumors have a specific mutation called ACCREDITED. So their subsequent treatment can be molecularly driven. And at times we were able to give that drug even before it was FDA approved, and even without proof that the mutation is there, because the radiographic criteria is so telling. And conversely, if it's IDH mutant, there's an IDH inhibitor drug also on the market as of last year. that can be given for these patients if they recur. And if it's GBM, it's other sort of trial options. So what we did for this patient is we did CSF study and we did the next generation sequencing panel. And it showed IDH mutation in the CSF. It doesn't mean that cancer is in the CSF, it's just the DNA mutation was detected in the CSF. So this patient was diagnosed without a biopsy as having an IDH mutated carcinoma. It's being treated. I saw him just a week or two ago after radiation. He's doing well and he doesn't have any need for other therapies, but this is very relevant for our patient care. This identification, molecular identification of tumors has moved beyond being something that, oh, now I know this would do worse or better. So something back to their treatment.
Is that just on the CSF?
Yes. Okay. Not the blood. This is CSF. The studies, the slides before were my own research at my lab, those were blood. Okay. CSF in the liquid biopsy world is because it's more intimately connected with the tissue, has a higher yield of detecting markers, whether it's ctDNA or RNA or but it is CSF, so sampling over time is a bit inconvenient to say the least for patients. So, but yeah, definitely ctDNA is much higher concentration in the CSF. A few slides ago, I mentioned the pathways that are impacted in glioblastoma for the most part, and CDK is one of them. And this is what I'm gonna show you next. So CDK inhibitors have been used in sort of drug repurposing standpoint in GBM trials over the last decade or so, many trials. Unfortunately, none of them made it to phase 3. So there's been initial, oh, maybe, and then phase 3 is where, you know, or phase 2 even in this case, this is where trials didn't proceed because for many reasons, all of which, you know, many trials are all comers, so recurrent disease. They're not enriching for CDK mutation, so it could be recruiting patients who don't have the relevant target for the drug. That's why it's not working. But then later they started including them, but they could be heavily pretreated patients because it's any recurrence is allowed for some of those trial results. So they're again diluted by very resistant disease activity. Or they could have lost a CDK mutation. Prior work I did, just because even when they're enriching for a mutation, it's based on the diagnostic tissue at diagnosis. But then over time, it can change. Trials that recruit for recurrent disease with a mutation, many times they don't specify we need a fresh tissue to be biopsied, at least the original one. But it can change even if it's a driver main mutation. I've seen it happen in many of my cases where we did these sort of 2 surgeries and analyzed. Up to 30% of the time, things change with gain or loss of previously mutations. And lastly, within the GBM world, unlike the systemic malignancies, what we see more of is CDK into E2B deletion, not the marker that the drug targets, which is CDK4 or 6 amplification. Even from the CBio portal, where you can query for gene frequencies and different databases for GBM, 50% is the deletion mutation. Only single digit or low double digit CDK4 and 6 amplification. So are we using them as a surrogate marker, but it's not really relevant? Perhaps. And that's the focus of my study, which was I have created cell lines from patient specimens. And because we do sequencing on the patient tumor specimen anyways, I knew ahead of time which cell lines have certain mutations. So I focus on that specific one. Is CDK into A2B deletion a relevant marker? And do we see differential response? So for these sort of neurospheres that were created, this is the set done like 3 times in triplicates of 4 different cell lines, 1, 5, 7, and 10. And it showed same treatment was given. They all had the same CDK and 2B deletion, but the response was different. So there is more to it than just you have the marker, the drug would work. Even those that have the same markers, they may or may not work. So my theory of what I'm working on is trying to make precision medicine move beyond targeting a mutation to a drug, which is a great way, but dig deeper into when is it not enough? And CDK was a relevant thing for us because that's a commonly used, commonly seen mutation and commonly used drug in our. All right, so we're a bit on time. And with a few sort of future perspective slides. So, one is I mentioned methylation profiling. It's a very robust sort of way to diagnose tumors. The classifier has been used over time. The most recent publication just from a week or two ago on 7,000 plus methylation profiles from 60,000 samples collected between 2016 and 2025 of all sorts of different primary brain tumors, including ones in particular that were hard to diagnose by basic criteria. And it's showed this you can do in one assay, get methylation subclass, what the diagnosis tumor is, and the copy number variant data. It identified novel entities. We used to have 91 with this classifier. They went up to 184. And it also it predicts prognosis. So this is what it kind of looks like. On the left is the right side of the screen is the training data where they put about 7,400 methylation profiles. And on the left is these profiles of 94,000 methylation profiles and how it sort of overlaps. Basically, you can detect and more accurately diagnose the type of tumor. Sometimes you don't need it because it's so clear. It's a GBM. It's IDH melanoma. You don't need it. But sometimes the tissue is so little or it doesn't fit anywhere. And what we do in our practice is we send them out to NIH or a place where they have these profiles and we get a more definitive diagnosis. It is superior in that sense of diagnosing. And it's making its way more and more in practice where it might play a role in future classification criteria. Additionally, moving slowly away from just DNA, RNA sequencing is another layer of actionable data. Methylation is for subtype classification, even protein sequencing. The point here is that integrating all this data together provide a decision support system for diagnosis, prognosis, and for treatment by relying more and more or by incorporating molecular understanding of tumors into what we do. So to do perhaps something similar to this is from publication also from a couple of weeks ago about the multi-omic data and their impact on the patient. This is not necessarily brain cancer, but we can use an example where the homogeneous patient population in gray before molecularly can be substratified in different colors, as you can see on the bottom. And each specific test is relevant. So it's not about doing A or B or C. DNA sequencing gives you certain information, RNA sequencing, other immunohistochemistry. I mentioned here is methylation, but you can extrapolate. Think of it as different snapshots of the same thing, giving you different results in terms of the biomarkers that can be used, in terms of the therapeutic action that you can pursue based on the results of all these different markers. So, then diagnosis and therapy, major metamorphosis happened over the last decade, and it is ongoing. We're not done, and we're shifting in the glioma world, similar to the broader oncology world, from just being tissue to being tissue agnostic, so molecularly driven, and biomarker driven. And research to this will result in more nuanced approaches to tackle this disease. As I mentioned, not just the BRAF inhibitor for BRAF mutation or a CDK mutation. We can go deeper and why within those who would respond better, who would respond less. So that's what the future holds. Better diagnosis, fine-tuned, personalized treatments. It's my own sort of interpretation of it. And I think that was the last slide. Thank you.
A few minutes for questions. Until we're fine, because we are connected online and see if the Zoom will have. Okay. I have a question. Can you tell us a little more about the methylation profile?
Yes.
How those cases, patients that we don't have a different diagnosis, how it's gonna differentiate? Is it gonna give you like is it GBM or glioma? How it's gonna help you with?
Yeah. So methylation is all based on the methyl groups on the genome, so the epigenetics of it all. It's sort of impact on or it's can be a way to distinguish between tumors, because just like different tumors can have different mutations, different tumors can have different methylation. So these profiles have been collected time and again, and that's how they were better able at distinguishing two tumors that genetically may have looked similar. The data that I showed, for example, the most recent publication was you're talking 160,000 samples, 7,400 methylation profiles, so really robust data. And that distinction, I showed a slide about survival with the IDH mutant, some of them did worse, and the IDH wild, some of them did better. Methylation only was able to predict that. So similarly, the tissue itself, when non-diagnostic, because the entities we have, the way we diagnose them, for the non-pathologist in the crowd, it's not always that clean. Like we have biopsy cues, we have diagnosis. It's based on many features. And sometimes those features do not like, hey, this could be A or B. It's not like we don't know anything. This could fit under myelocytic carcinoma, but also fit under a new molecular divinity. Methylation is much more sensitive. That's how we utilize it. It's a more robust diagnostic platform when the basic studies are not giving us answers. And with there is in the field, the fact that we can get these answers now faster, we'll be able to use it potentially. Right now it's a handout we send with that evaluation. Germany wants to send. Yeah, there's some data we send. But they tested itself. The case we had in the US, if they were doing a lot of this motivation studies.
And then do you foresee the future for the ADH mutant gliomas or gonna get rid of the grade 2 and grade 3? Or?
I think so. I think in many ways, in fact, we have. It's rare that we still do, but it's rare that we, at the observation level, for example, maybe you then no risk factors, you're grade 2, okay to observe versus grade 3, maybe 3. But it's sound that there are more data that are coming out. There really is like there is IDH fault and there's everything else. And the extra mitotic, because the difference between 2 and 3 is extra mitotic triggers. Actually, may not mean as much. And the data that analysis of all these trials sort of allude to the same thing. So 1P90Q that's distinguishing more than grade 2 versus oligos that have both IDH and the other 1P90Q, the best, and the IDH mutants second best. There's 2 or 3 is slowly, gradually making less and less elements. Similarly in trials, they got 3 now. IDH mutant trial, IDH wild trial.
Thank you so much. I really enjoy it. So we're gonna move to the next speaker, which is Dr. Witt. He is our medical oncologist at University of Illinois, who is specialized in melanoma and lung cancer. He has dedicated himself to precision oncology treatment. He's actually directing our tumor boards were actually for all comers, not only lung and melanoma patients. He's trying to direct to see, based on their molecular makeup and their tumoral mutations, what is the best clinical trial for those patients. So we're really have taken a lot of benefit from our patients with your knowledge. Today, he's going to talk to us about melanoma and how the updates about immunotherapy and targeted treatments still evolving on which one to prioritize first. So please update us. We're happy to have you here.
Okay, thank you so much. Thank you, Laura, for the slides for me. So I think I know a lot of the folks here, most of the folks here I think know me mostly from a lung side. So it's I'm sure it feels weird seeing me talk about melanoma, but I actually am the main melanoma cutaneous oncologist both at UIC as well as Cook County across the street. So I do have a lot of experience taking care of these patients for the past few years. There's a lot of principles that switch over between how I take care of patients with lung cancer and how I take care of patients with melanoma. A lot of overlap, but also some areas where there's a little bit of a difference. So we'll be talking about some of those major updates today. Next slide. These are my disclosures. For full transparency, we will be talking about products that are made by Merck, Pfizer, and Bristol Myers Squibb. We're talking about treatments in the melanoma space today. Next slide. So the main objectives, we'll be talking a lot about perioperative therapy. In the lung cancer space, there's been a lot of changes with neoadjuvant perioperative chemoimmunotherapy. And just like that in the melanoma space, I think the standard of care has really shifted to using immunotherapy in the neoadjuvant and perioperative space as well. We'll be talking about for advanced patients, how to choose the best regimen in the first line setting, and then also what are some of those options in the second line setting as well. Next slide. So this is my type of schema and how I think about patients with locally advanced, but also resectable stage 3 or stage 4 melanoma. So you can really see here, there's two different paradigms, but both of them do lead to the patient getting immunotherapy in the neoadjuvant setting. If I have a patient who's younger, that you'll see here on your left, who has a better performance status, who's able to get immunotherapy, I am favoring the ipi-nivo regimen where they get 2 cycles of ipi-nivo up front for the NADINA trial. And then based on their surgical and pathological response, that really guides whether or not we're going to do adjuvant therapy or not. And that's we'll go into that trial a little bit more, but that's a really interesting and I think fascinating clinical trial design, the way they design whether or not patients will get adjuvant therapy based on the pathological response, which we really only see in breast cancer, but we don't really have that in lung cancer. So melanoma and the NADINA trial, I think, was really interesting how they designed that. On the flip side, if I have a patient who is maybe a little bit older, has more comorbidities, which is, to be honest, a lot of the patients that I do end up seeing at both places, I do favor more of a neoadjuvant single agent immunotherapy approach with pembrolizumab. That's for the SWOG S1801 trial. And for those patients, they end up getting surgery after 3 cycles of neoadjuvant pembro. They are also going to get adjuvant immunotherapy regardless of their pathological response. So you're seeing, again, both paradigms where patients are getting neoadjuvant immunotherapy, but based on the regimen that they get, the pathological response may or may not determine whether or not you're doing adjuvant therapy afterwards. Next slide, please. So what tools should we use? Because we have so many different options, and Dr. Weinberg is going to be here later today. He's got all the lung stuff. He always has great memes and great pictures in his lecture, so I'm trying to. So next slide, please. So looking at SWOG 1801 or perioperative immunotherapy, this was really a major trial in the melanoma space. They took patients who had stage 3 or stage 4 resectable melanoma. All of those patients got 3 cycles of neoadjuvant pembrolizumab up front, then got surgery, and then got a year of immunotherapy. So that was the experimental arm that you can see in the bottom, versus the standard of care, which at that time was really just surgery followed by 1 year of immunotherapy afterwards. And they wanted to see how many of these patients were surviving without their cancer coming back. Next slide. And when you look at the event-free survival, we have the group in blue, which is the neoadjuvant and adjuvant group, compared to the group in red, which is adjuvant only. And you can see a pretty clear event-free survival benefit for these patients who are getting that perioperative approach. And this is the same type of benefit that we're seeing in lung, that we're seeing in a lot of other diseases when you're doing this kind of sandwich approach of immune treatment before surgery and then immune treatment afterwards. We know that melanoma is an inherently probably the most immunogenic tumor that we have. So it makes a lot of sense, in my opinion, to try to give your immunotherapy up front when you have as much tumor bulk, as much tumor antigen as possible to train the immune system in a way when that tumor is there, then do the surgery, and then do the year of immunotherapy afterwards. Next slide. Now, this was contrasted with a trial that came out very soon right after it, called the NADINA trial. And this trial was run over in Europe. And it's one of the most, I think, kind of innovative clinical trial designs that we've seen in a long time. This was a trial where they took patients, same population, except it was only stage 3. So SWOG 1801 included patients with both stage 3 and stage 4 resectable melanoma, whereas NADINA was stage 3 resectable only. These patients were randomized to either get 2 cycles of ipi plus nivo. What's interesting here is that ipi was a flat dose at 80 mg, or in the adjuvant setting, they would get surgery and then just 1 year of immunotherapy. So again, that's standard of care. What's interesting is if you look at this kind of top diagram here, after those 2 cycles of neoadjuvant ipi-nivo, then they use the pathological response to determine whether or not the patients get more treatment. If the patient had a major pathological response, which they said is 10% or less tumors when you actually take the cancer out, they actually stop treatment at that point. So there's a course where these patients could get just 2 cycles of ipi/nivo, have a major pathological response, and stop all treatment after that. However, if they didn't have a major pathological response, and then they would complete 1 year of either immunotherapy if they're BRAF negative, or do a switch maintenance where they then switch to BRAF plus a MEK inhibitor for the remaining of that year. Next slide, please. And here we see the event-free survival. Again, the blue group is that neoadjuvant plus minus adjuvant group versus the red, which is the adjuvant only. We do see, again, an event-free survival that benefits the arm that's getting that perioperative approach. And I think between the DINA and SWOG 1801, myself and pretty much every other cutaneous oncologist I know has really adopted a perioperative approach, trying to get immunotherapy in these patients as soon as possible before surgery, again, while that tumor bulk and tumor antigens are still issued. Next slide. I think what was really remarkable about the NADINA trial, you see here on your left, is the actual pathological response. And you can see here that either based on local assessment or central review, the major pathological response with just 2 cycles of ipi/nivo was close to 60%. Meaning that in this trial, 60% of patients, again, were getting just 2 cycles of ipi/nivo, surgery, and then stopping all treatment after that. And what we found is that if you look at based on the response, so the deep green or even the light green, if you had a patient who had a PCR or a near PCR at 1 year, which is 2 cycles of ipi/nivo and surgery after that, 95% of those patients were still event-free, and still event-free survival, meaning their cancer didn't come back and they were still alive at that time. So for me, it brings up a huge point, right? That these patients are getting such a fantastic pathological response and having also a year later still, pretty incredible outcomes. What is the benefit of that additional year of immunotherapy? I think that starts to become a question. Do we need to give additional immunotherapy to these patients who are having a great pathological response? These are questions that we're exploring in the lung side, that we're exploring even in patients who get pembrolizumab. I don't think it's quite answered. But to me, I think this data suggests that pathological complete response, at least in patients with melanoma, is a very strong predictor about it. And then, we've talked a lot about efficacy, but I think anytime you're talking about immunotherapy, single agent or dual agent immunotherapy, you do have to think about the side effect profile. And so I've put together some of the side-by-side data here. We've got NADINA on the left, SWOG 1801 on the right. You can see here that the event-free survival for your experimental arms is going to be a little bit better with NADINA compared to SWOG 1801, knowing that SWOG 1801 also included some stage 4 patients, so that population is going to be sicker at baseline. But one thing I do want to point out is when you look at your complete pathological response rate, you're looking at 47% with ipi/nivo compared to just 21% with pembro. But when you look at the grade 3 side effect rate, you're looking at 30% with ipi/nivo compared to just 12% with pembro. So this comes down to, I think, the classical decision that a lot of us in cutaneous oncology are always making. Can this patient tolerate dual agent ipi/nivo, dual agent immunotherapy, knowing that that's going to be the stronger agent efficacy-wise for them, but is also going to have sometimes 2 to 3 times the side effect risk as giving just single agent immunotherapy. And so it goes back, next slide, please. It goes back to this paradigm that I think about. If I have a young, healthy patient, excellent performance status, who I think could tolerate the possibility of having that side effect profile, I will go for the ipi/nivo for that patient. But if I feel that the patient's older, I worry that the side effects might really knock them back, might even preclude them from getting surgery. That's a patient that I'm thinking about single agent immunotherapy. So just to wrap up, this is kind of my approach to resectable melanoma. SWOG 1801 and NADINA, I think it really pushed us to think of perioperative immunotherapy as the standard of care. And that's what is in the NCCN guidelines currently as well. It really comes down to, do you have a patient you think can tolerate dual agent IO? Or is this a patient who's a single agent immunotherapy candidate? I think one big unanswered question is, what if I have a patient that I do the SWOG 1801 neoadjuvant pembrolizumab, let's say they get a PCR, should that patient or does that patient need that additional year of immunotherapy afterwards? I think that question's unanswered. If I have a patient who really doesn't want to get any more treatment, I would feel a little bit more comfortable knowing that they got a PCR and potentially stopping. but I don't think the data currently suggests stopping for that pembrolizumab, that single agent immunotherapy patient quite yet. This data really only applies to the stage 3 or stage 4 resectable setting. So if you've got a patient who's got stage 1, stage 2 melanoma, upfront surgery, I think is still the standard of care. I think we'll see in the next couple of years whether or not immunotherapy plays a role in those stage 2 patients, but for now it's really just stage 3 or stage 4. And then this benefit is seen regardless of BRAF status. So both the SWOG 1801 plus the NADINA trial both included patients who had BRAF mutations. We have not seen this type of benefit in some of the smaller trials that have done neoadjuvant BRAF MEK inhibitors. So really, I think the standard of care for those patients is still immunotherapy. And I think the one kind of interesting question is in NADINA, if they didn't get a PCR and they were BRAF positive, they would actually switch them from neoadjuvant immunotherapy to adjuvant BRAF MEK. Is that better than continuing on IO? I don't know, but it makes sense to me that you're not getting a pathological response with immunotherapy to switch to a BRAF MEK targeted. To me, that makes a lot of sense. Next slide. So that was perioperative, but how about for these patients who are in the advanced setting, who have cancer that's unresectable, and we have to really just think about systemic therapy for them. So this is kind of my approach to it. There's a lot of different arrows here. We'll start at the bottom, and let's assume that you've got a patient who's BRAF negative. And so BRAF is actually the most common mutation we see in patients with melanoma. It's that BRAF V600E mutation, probably occurs in about 40 to 50% of patients with melanoma. Interestingly enough, we also see this in about 1 to 2% of patients with lung cancer. I have a few patients of my own who have this mutation. It's a bit of a different paradigm, how we treat BRAF in lung cancer and how we treat it in melanoma, but the drugs are about the same. But let's assume our patient is BRAF wild type. Then I really think about fitness. And again, it's that question of how much do I think this patient can tolerate and how aggressive do I want to be? Ipi-Nivo for the first-line treatment of stage 4 melanoma has really been the standard of care for quite some time based on the Checkmate 67 trial. You're talking about a median overall survival in a stage 4 cancer of 72 months. And there's really no other disease that I know of in the stage 4 setting where you're seeing a median overall survival that's 5, 6+ years. So that's long-term survival data that's really there's nothing really in lung cancer that's even close to that, and not a lot of cancers can get to that type of long-term survival. However, we know with that Ipi-Nivo regimen comes a lot of toxicity. Treated a lot of patients with Ipi-Nivo, unfortunately had to deal with colitis, dermatitis, thyroiditis, all types of side effects. We know that grade 3 side effect rate with Ipi-Nivo is close to 60, 66%. So more likely than not, you're going to have a patient who's dealing with a side effect that's going to stop their treatment, either lead to dose reductions or dose delays, or even having to stop treatment. And so that's the challenge with starting patients with Ipi-Nivo. You know that long-term, this is probably the best thing survival for this patient, but can they tolerate some of the side effects that come with it? But if I have a patient who's older, who I don't think could tolerate some of the side effects, I've started using relatlimab nivolumab, which is FDA approved for the first-line treatment of these patients as well. It's also built on the backbone of nivolumab, your PD-1 inhibitor, plus relatlimab, which is the new LAG-3 inhibitor, so they're given in combination. It's also like Ipi-Nivo, a dual immune checkpoint blockade, but we've actually found that the side effect profile with that has been much lower than what you see with Ipi-Nivo, and we'll get into some of that data here. You do have the ability to potentially cross over if you start a patient on one of these and then you start to see progression. But I'll say right now, TIL therapy is currently FDA approved. It's being done over at University of Chicago, Northwestern. We've done a few at UIC, but those are really the high volume centers. And it's really become, I think, the standard of care for a fit patient who's immunotherapy refractory. So it's a little bit easier in that BRAF negative space, but how about for those patients who do have that BRAF mutation? So you can see here, forget this incobini that's below the visceral crisis, that's there. So if you have a patient who's BRAF positive, in lung cancer and in melanoma, it's a little bit different. In lung cancer, I always tell my trainees that if you have a target in the stage 4 setting that has an FDA approval in the first-line setting, I would go for the targeted therapy first. And we know that for EGFR, we know that for ALK, we know that for a lot of these different mutations, and BRAF for me is the same as well. But what we found in melanoma is that it's a little bit different in that we actually found that for these patients who have a BRAF mutation, when you start them with immunotherapy first, on average, these patients live longer when you start with immunotherapy first and you do targeted therapy second, rather than the other way around. Because of that, for most of my patients in that situation, I will start with immunotherapy first and save that BRAF MEK for the second line, with one kind of key caveat, and you can see it here. For those patients who are having visceral crisis, so let's say they're either having symptomatic brain mets, they're at risk for they're at a pain crisis, their liver is about to shut down, they're having respiratory distress because of the tumor burden. One issue that we see with immunotherapy is, yes, it works really well for a long time, but it takes a while to work. It can take 8 to 10 weeks. And I've actually seen a few of my patients who've had BRAF mutated cancer, who've been very symptomatic at visceral crisis, and we've started them on treatment. And I've seen some of these patients respond within less than a week in terms of even feeling some of these lesions that they've had shrink in that amount of time. So if I need a patient to have a rapid response, I will think about starting BRAF MEK therapy for that patient up front. But I will kind of think about switching to immunotherapy as a long-term response. And we'll get into some of that data next. Next slide, please. So immunotherapy combinations, next slide. So to give you a kind of overview, I know we have some learners here as well. So this is kind of the interaction between your immune system, as well as antigen presenting cells and tumor cells. So we know that for a long time, we've been thinking about PD-1 and the PD-L1 interaction and the tumor hiding from the immune cell in a way. And that is occurring within the actual tumor microenvironment. However, upstream of that, in the actual lymphoid tissues, you have your dendritic cells and your naive T cells, and that's actually where the CTLA-4 interaction is happening. So that is where the T cells themselves are being primed to work on the rest of the body, and that is where CTLA-4 inhibitors like ipilimumab are happening. The reason this is important is if you think about lymphoid organs being upstream, and these are kind of more naive T cells, compared to target tissues kind of more in the tumor microenvironment. The reason that we see so much side effects, but also so much efficacy with these CTLA-4 inhibitors is that it's happening at a very upstream level. It's happening in these naive, kind of unprimed, unactivated T cells. And so that's why you're seeing kind of a wider spread of action with CTLA-4 inhibition, but also a much higher side effect rate. That's kind of where this new immune checkpoint target, LAG-3, comes in. LAG-3 is happening at the target tissue level, so at the same level where you're seeing PD-1. And so that's why even though it's an immune checkpoint that's hitting at the same time as PD-1, and we're getting some of that dual IO efficacy, you're not seeing as much toxicity because it's targeting at the target tissues and not kind of upstream like CTLA-4 is. Next slide. So looking at some of the major trials, Checkmate 67, this is really the landmark trial in advanced melanoma. In this trial, they took patients with stage 4 melanoma, randomized them to 1 to 3 arms. They were either getting Ipi-Nivo, just Nivo by itself, or Ipi, which was really the standard of care at that time. We're seeing in red, this is the arm that's Ipi-Nivo, green is the arm with Nivo, and gray is the arm which is Ipi by itself. And you're seeing very long-term follow-up, right? So we've got, I think, 10 years of follow-up. So at 10 years, the overall survival for the Ipi-Nivo arm is still 43%, with a median overall survival of 71.9, or about 72 months for this group. So this is the longest running trial that we have in melanoma that's shown this kind of level of efficacy. And this is really, for a long time, has been really the benchmark and gold standard for overall survival, at least in stage 4 melanoma. Can you go back? Sorry. So I think the big challenge again, though, is when you look at, yes, this is really great data, clinical efficacy wise, more than 60% of patients are going to have a grade 3 adverse event with this treatment. And so this is something that I prepare patients for. I think this, again, if you can tolerate, is the best long-term treatment for you, but more likely than not, we're going to see a serious side effect on this medication. Next slide. And that's where Relativity 47 the trial came in. This trial looked at the same population, so stage 4 advanced melanoma. They randomized them to 1 of 2 groups. One group got Nivo plus relatlimab, which is a new LAG-3 inhibitor. The other group just got nivolumab. The group that's in blue is Anivo plus Rela. You can see that that median overall survival is about 51 months, with 49% of patients still alive at 5 years. But the grade 3 adverse event rate was only 22%, compared to, again, in Checkmate 67, you're seeing a grade 3 adverse event greater than 60%. So yes, there's a little bit of there is about a 20-month difference in overall survival that we're seeing, but you're seeing an adverse event rate that's a third of what we see with Checkmate 67 with ipi. Next. So this is a side-by-side table, just looking at these two regimens again. We've got Relativity 47, our Nivo-Rela arm here, Checkmate 67, our ipi-Nivo arm here. When you look at these again, side by side, these are two different trials, but I do like to look at these efficacy outcomes. Your median PFS is going to be similar between the two. Where you're going to see a really big difference is at OS, right? So your median OS with ipi-Nivo is going to be about 72 months. With Rela-Nivo is going to be closer to 51 months. But again, your side effect rate is going to be substantially different between the two. 22% grade 3 treatment-related adverse events versus 62% with ipi-Nivo. So this is the constant kind of decision that I'm making with the new patient with stage 4 melanoma, is it's always a balance between, are we shooting for that 72 months and being aware of that 60% adverse event rate? Or are we okay with the 51, knowing that I would much rather not expose that patient to that high risk of side effects? Next slide, I think this will pull it up. And I think the folks who made Relativity 47 thought, well, if ipi-Nivo is great and Rela-Nivo is great, why not just throw all three together and let's see what happens? So this was a phase 1/2 trial called Relativity 48, where they actually gave patients ipi plus Nivo plus relatlimab. It's a small trial. I think it only included about 40 patients. And they actually found some pretty, I think, remarkable outcomes so far. They don't have long-term data on it quite yet. But the median OS is still unreached. Your overall response rate jumps from about 40% all the way up to 58%. And kind of interesting, the grade 3 treatment-related adverse event rate was only 39% in this trial. Will that hold out over time and in a larger study? Probably not. This is not FDA approved yet. They're going to run, I think, a larger phase 3 trial to look at this combination. But I would predict probably in the next 5 to 10 years, we'll probably see if this data pans out, will we see a world where maybe you have a paradigm of like high-risk patients who get triplet therapy to start off with, and then maybe these lower risk patients who choose one of the doublets. We'll see. Next slide. So how about for these BRAF positive patients? Next slide. So the DREAMseq was a really instrumental trial run by one of our NCI centers that are NCI organized trials that looked at this question of, okay, these patients who are BRAF metastatic melanoma, is it better to do BRAF MEK therapy first and then switch to IO? Or should we do IO first and then switch to BRAF MEK afterwards? Next slide. And what they found is that the arm in blue is the arm that led with immunotherapy first. So they got ipi-Nivo first, and then upon progression, switched to BRAF MEK. Whereas the arm in red is the group that did BRAF MEK first and then switched to immunotherapy. And you can see a clear OS benefit at 4 years and even extending farther, as well as a second-line response rate of 70% for BRAF MEK in the second line compared to only 46% for immunotherapy in the second line. However, one thing that I do want to point out, and the reason I think about this visceral crisis quite a bit, is if you forget about all this side of the trial, and let's say we stop the trial at 6 months. If you stop this trial at 6 months, you'll actually see that the BRAF MEK arm seems to do better than the IO arm. And it's always an interesting phenomenon based on where you cut off the data. But this comes back to that thought of if these patients have a high visceral disease burden, they're at risk for visceral crisis, maybe these are patients who cannot wait for immunotherapy to take effect and to work long term. So for me, the way that I think about this is if I have a patient who I think I can wait for the immunotherapy to kick in, that's a patient I will favor IO first because of long-term benefit. But if I need something to work really quick, that's where I really think about starting with BRAF MEK first. Next slide, please. So how about, instead of switching things around, how about we think about a sandwich approach. And there's a lot going on here, but for those of us who are thinking about sandwiches from like a purist standpoint, from a chaotic standpoint, this is one of my favorite charts. So you've got structural purist and ingredient purist in the top left. So your very traditional sandwich. And then you've got structural rebels and ingredient rebels in your bottom right. And for those people, they would actually call a Pop-Tart a sandwich. So there's a lot of different ways to think about how you can create a sandwich. And we'll talk a little bit more about melanoma and how we sandwich some of these regimens together too. Next slide. So that comes to Succumbent, which is a big trial that looked at, does a sandwich approach help some of these patients? And so this trial actually was designed fairly similar to the DreamSeq trial. If you look at the two top arms, so arm A and arm B, it's a very similar design. You start with BRAF/MEK, you switch to immunotherapy upon progression, or vice versa. But arm C, I thought, was a really interesting trial where they led with BRAF/MEK, and they did an 8-week induction. So you do Enco/Bini for 8 weeks, and then at 8 weeks, you actually then switch that patient to Ipi/Nivo. And so you're not waiting for progression, you're actually switching them at that 8-week mark. And they wanted to see how did all three of these arms do. Next slide. We actually see that the arm that's in red, which is arm B, that's our Ipi/Nivo arm that starts off first and switches to BRAF/MEK upon progression. This arm that's in blue is our arm that starts with BRAF/MEK and then switches to IO upon progression. And then this arm in green is actually that sandwich arm. So it's the arm that starts with BRAF/MEK just for that limited 8-week induction and then switches to immunotherapy. And you can see a clear difference between our red and our blue arms. But what's interesting is that the red arm and the green arm, so the one that's sandwiching, seems to have somewhat the closest OS compared to just starting with immunotherapy. And so when I think about these patients where I really need to start with a targeted therapy up front, I've started to lean more and more towards doing this kind of sandwich approach. And actually I have a patient that I started on BRAF/MEK therapy fairly recently. We were doing just that. It's a young patient, 29-year-old, had mets, unfortunately, all over the place. Visceral crisis, tons of pain. We had to start him on targeted therapy. But now that we've shrunk his tumor by 50%, now I'm thinking about, this is a 29-year-old, he's got 3 kids. I'm thinking about the next 5, 10, 15 years of this guy's life. I think we've gotten out of that first 6-week period, but how do we think about the rest of his life and maximizing his survival? For a patient who I start on targeted therapy, I really think about switching to immunotherapy to max out that long-term benefit. And actually, Dan Olson, who's Dr. Olson at University of Chicago is one of my colleagues, has done some research on this. And what they found is that if you give the patients BRAF/MEK therapy for too long, it actually creates an environment where the T cells in the immune system actually starts to get more exhausted and they become less responsive to immunotherapy after a long-term exposure. And so a big benefit is actually trying to get the immunotherapy in the patient as soon as possible. Next slide. And then for those patients who have symptomatic brain mets, and thanks so much for Dr. Daher and Dr. Moraka, they see all of these patients with me, and I'm so helpful with their help for some of these patients. But these melanoma does like to go to their brain. It's always been a challenge. How do we treat these patients with brain mets? Unfortunately, these patients do very poorly compared to the rest of the population. There's a study that came at ASCO last year called the S2000 study, and they wanted to actually look at this question of, well, what if we gave patients a triplet regimen to start off with, where they were getting Nivo and Brafnib and Binimetinib versus those patients who were getting just Ipi/Nivo. And what they actually found is that the group that got the triplet therapy had a response rate of 57% compared to only 15% in the Ipi/Nivo arm, and their median progression-free survival was 6.2 months versus 1.4 months. It's a very small study. It's only about 30 patients, but it's hard to find these patients and run a large clinical trial for them. But for me, because unfortunately the prognosis of these patients can be pretty dismal, I'm willing to be more aggressive up front. And so now I'm considering a triplet regimen for these symptomatic brain met patients up front. Next slide. So second line, next slide. Tumor infiltrating lymphocytes, TIL therapy. This is really exciting in melanoma. We would actually do a procedure where they cut out the patient's tumor. They will harvest the lymphocytes from that, expand the population. They actually get admitted to the hospital for a couple of days, get a lymphodepleting chemotherapy regimen, kind of like a stem cell transplant, and then they infuse those TILs back into them. Next slide. And in this trial that was led to the FDA approval, you can see this plot of all the responses. Again, not everybody is getting a response, but in this traditionally immunotherapy refractory population that unfortunately doesn't do that well, we are seeing about 30% of the patients are getting a response, and you are seeing some deep and durable remissions in some of these patients as well, including about 6% of these patients who are getting a CR in the second-line plus setting. For those patients who do get a response, the median duration response is lasting about 3 years or a little over 36 months. So it is, in a way, still kind of a Hail Mary for some of these patients, but I think it's still an excellent option in these patients that really don't have options otherwise. And how about switching over? I'll say that my clinical practice and the data isn't that fantastic, to be honest. You're looking at response rates of between 17 to maybe 30 to 40%. There's not a whole lot of options, unfortunately, once you get in the immunotherapy refractory stage. So if the patient's not fit for TIL, I'll consider switching from Ipi-Nivo to Rela-Nivo or vice versa. But unfortunately, we just don't see a lot of great responses for those patients. Excellent. So just to summarize, I'm always assessing for resectability for these patients, even if there's a patient that I start on systemic therapy first. Let's say they have a fantastic response. If they have limited sites of disease, I'll talk with my surgeons and my radiation docs to do definitive therapy. If there's only a limited amount of disease after that first treatment, after those first few treatments. Dual immunotherapy has really kind of moved up in my toolbox for these patients. It used to be that I would do single agent immunotherapy for the patients I was worried about. But for me, the safety data between the relatlimab nivo and single agent IO is fairly similar. So that's really replaced single agent IO for me. But if I have a patient who's young and fit, I still try to go for Ipi-Nivo for these patients. And then your second line options include BRAF, TIL, or even an IO combo switch if needed. Next slide. And that's it.
Hi. So two quick questions regarding the neoadjuvant idea. You mentioned this, the exposure to large involved and also trained T cells to basically work with, and it's wouldn't have done it. Have they looked into the sort of disease burden in that sense? Like, was the larger disease burden the more exposure, or are they stage 3, 4? It sort of normalizes and not much difference between disease burden arms.
Yeah, that's a good question. Like, if you have a larger disease burden, that correlate, and then if you have a greater response, does that correlate? I don't think they've looked at that in particular. I think by the time they're stage 3, you've already had nodal metastases. So I think the hard part is quantifying just like how much tumor are we dealing with some of these patients. But I don't know. I think it's in my opinion, I think there's like a threshold of tumor that you have to have in order to get that immunogenic response. But I think past that threshold, having more tumor, I don't know if that correlates necessarily with a better response.
Really quick while I have the mic, the DeepSeek, the sequence, you mentioned T cell exhaustion. Is lymphopenia part of it? I mean, I don't use BRAF as much, but BRAF might cause lymphopenia, and that, in theory, may be why subsequent immunotherapy is not good. But is there non-lymphopenia?
I think the lymphopenia was a part of it. I'll have to look at Dr. Olson's work a little bit more in detail, but he did, I think, characterize more of a T cell exhaustion kind of like phenotype in these patients who've been BRAF MEK exposed for quite some time. I think that explains why your response rate to Ipi-Nivo and immunotherapy in the second line is only maybe 30% compared to in the first line, you're gonna be closer to 50%.
I think it's also in the neoadjuvant trial, where you had 60% complete response. Did they have the breakdown who were the ones with the BRAF mutation and BRAF wild type?
So it was pretty, from what I remember, pretty similar rates of response between the BRAF wild type and the negative. And we've seen that, I think, in just the general immunotherapy literature, is that it doesn't really, immunotherapy is effective in BRAF mutated patients, but it doesn't necessarily, I think, predict whether or not they'll get a response. It's more that these patients just have another option.
And have they have they tried, similar as the brain met study, as the neoadjuvant for the BRAF mutant patients to do the triple therapy? upfront, like neoadjuvant?
Yeah, no, nobody's done triplet therapy neoadjuvant so far. I think that'd be an interesting trial. Certainly BRAF MEK has its own side effects that come with it. And so to be honest, like Ipi-Nivo is probably the most amount of side effects that I would feel comfortable exposing in that neoadjuvant space, because we always, I think one worry is if the patient gets too sick from side effects, you can lose also your window of resectability. And some of that data is pretty fantastic with the IO combination. So I don't know if anyone's interested in pushing that question of combining it. I would save it more for the adjuvants.
And was it, when they did the triple therapy for the brain mets, was it very high toxicity with the combo?
Yeah, I think it's kind of very similar levels of toxicity. I think it was about 60% grade 3 adverse event rate. So I don't think you necessarily add a whole ton of toxicity, but it's just the known toxicity that you're going to have. But I think the challenge is in the Ipi-Nivo group, even with just getting Ipi-Nivo, that PFS was like 1.5 months. So the challenge is I think these patients are just so sick that, and I think they're highly symptomatic, and these patients were symptomatic at baseline, that I think just getting any treatment to control the brain mets is the goal there.
Do we have any questions from the? Thank you so much. For a break. We're a little bit earlier, so we are 10 more minutes for snacks and drinks. So we're gonna come back at 4:35, the next session.
Thank you, say it, hold on. So you have the derm.
He's very nice. I never met either of my kids, so. Yeah. They did, and there weren't any fights, you know, so, but it was, I mean, absolutely fantastic. And the band, I mean, there was not one person there not in like Black Ops here, except and my husband. Oh my God, it was crazy. It was like, oh, we tried it. I just took him for you, but yeah. So he's definitely.
Oh, yes. On the patio with home days.
So you guys both run lunches?
No.
I don't think they have. Well, you didn't miss lunch. I mean, there. Yeah. I don't actually know what that looks like.
One expert on side or
Sure.
like the.
I know that would have been like tags, he's like a gem, like ridiculous. Yeah, they had to get over.
Yeah.
Just, yeah, wants to do.
That is good. So I make sure share better say. Yes. No, I'm saying, no, I'm saying. Sorry. Yeah, yeah, it's nothing. Like stuff. Seriously.
No, and I.
It's just that opening of the.
Yeah, I think it's just trying to. It's good. It'll be fun if they have a trial that they put it up across the.
They have like a study.
Yeah, they have. Like Sleeper, we have, I actually loves it. That's cool. Okay, fun. These are not Rutgers science. Yeah, I'm like itching to go back. In fact, like my actor, the center should do like, she's 10 seasons, get back in 5 black weeks, 5 fair. Just like, that's it, that's all. But have like some combo package. I don't think it is, but, she does. But it's, yeah. That insanely expensive, you know, I mean, they like those when I used to, but you know, hockey, there's like really not a bad scene. The rink is so big, it's not like, yeah, it wasn't like, so. You know, so I grew up in Detroit and, you know, like big Red Wings people, so we did watch it like growing up, and I've definitely been to my fair share of Red Wings games, and then I went to she's the one I went to high school to play hockey at Michigan State, so I went to a bunch of Michigan State games. You didn't, but now I don't, I mean, I haven't watched it many times. I did meet.
That's what people say. On TV, I gotta go.
A lot of it is just the atmosphere, the bands, you know, and just like that sort of vibe, that.
Kids, intermission.
Yeah, oh my god, they were so cute.
This year also, you can't watch it on TV. Like subscriptions for like Bulls and Blackhawks and so like, I think you need to go in person anyway.
I mean, it would, I was, that, I mean, it was, and I was surprised, because they're not that good, I mean, they're like 6.5 or something, they're like not good. But yeah, it was super fun, because yeah, and for like my kids who, I mean, we did the Michigan State hockey at Wrigley Field last winter. That was their first like probably big hockey game they went to, but it was also like -10, so it wasn't a great experience being outside.
Did you get an essence?
Rather than telling them to stop. They did like, I mean, when I was there, I bet that was right after Redmond State did that frozen of the college. I don't think it was. Yeah. Yeah, it's cool. Yes. Yeah, I know that I talked today for like just touch base on like expectations. No, it's not today. It's not today. I have a conflict. I don't know that I'm, but I'm gonna try to stick out. Yeah, I can't really. Both days. Yeah, I get home from Palm Springs Tuesday night, and then both of them are in the States. I'm like, Larson, what are you thinking? It's probably close for you. But like, I mean, it's like an hour. You're kind about.
Take mine.
Well, I mean, Danielle and I were like, who suggested Buckman Estates? I mean, and also I'm sensitive to the Wisconsin, right? So I guess like, okay, that's probably be easier than coming all the way down. But like, they're gonna spend the night anyways, so who cares? Been to that place before, not eating, they did like, there was like a big vintage. I usually go to that.
Yeah.
I mean.
Yeah, we go every.
Yeah, Simon came to one, and there was nothing. So I depends on what. Well, that too, Danielle's like, I mean, should I stay in Macy's? I'm like.
Less than summer. Yeah. So it takes a little bit.
Yeah, yeah. I feel like it depends. If they want that, or if they then like seeing some of our students.
Go to their house. Like Perkins, I love it.
Oh, yeah.
They're so high.
It'll be fine. I probably won't be able to stay. I'll invent one.
Very exciting. Like, yeah,
Oh.
houses. I mean, like, I think you guys went there.
Ah, yes.
Whatever, it's gonna be nice.
Oh.
Don't sometimes have dinner downtown.
And I'm actually
Stop by.
a
I was talking to
with my best friend.
watching a show or they're out of
Where's he going?
and then it's like.
And then we have that meeting right on top of it. Like, I might be able to stay for dinner and then have to.
The directors that he house to that. And then he had like.
It's very unexpected. So then like treating and whatever. I didn't have to plan it. I mean, it's. But
as
maybe 50 minutes. Yeah, it's probably further.
Yes, back this. It's actually just.
Oh, yeah.
Walk to like a small downtown.
Danielle. This Danielle is hoping that.
You know, it's a shared.
Because she takes, like, yeah, if you're right, let's see.
Always have.
Because she's got something
Yeah,
Just
that she.
go like.
That's like there for six.
Next time you're.
Yeah.
Sean.
No, I mean, even I could just text you,
Yeah, yeah.
just meet you there.
Yeah, I'll show you. down.
I'll be there for.
I
snapped
snapped
out
out.
or something.
I still can't believe.
It's also.
Like, in the summertime.
It starts sort of in the middle of the day on Thursday, so that bad getting out there, and then if I stay for dinner, I'll be that bad getting back. But the next morning.
That's what I really see more. Drive every time to see.
Yeah, good, good.
Right downtown, and then jump off the bed where I was, I'm staying at, like, make it easy, you know? Yeah, right to the third, there's a big, beautiful train station, probably, not 5 minutes ago. Right there. But I thought it was there.
Oh, no, you're totally.
Yeah,
How much time we had.
I feel like if you're, even if you're.
Yeah.
And, yeah, so they're my, right, so that's why I'm saying, let me know.
It's okay.
The
Don't worry about it.
MISD.
It's totally fine.
So you're-
We have to really.
Well, it's funny, I was setting up a meeting for advocate and the guy was like, where are you staying? And I was like, oh no, I'm like coming up to have lunch with you. No, I mean, that's just a day trip. But he was like, you serious? I'm like, but that's what I'm saying, like, because it's still not that big of a
Yeah.
deal, whatever that. So, yeah, you just, where do you want to meet for lunch? And hopefully it's not phenomenal.
It might just be,
Happy to just.
To be honest,
lunch
we're
and
gonna
then
hang
drive
out.
in. No, I mean, like, but that's okay, like, I don't really care.
Yes.
I feel like.
It would be cool, yeah.
Hey, when
Good thing they don't have election hours, because then it's really, we all.
I thought this would have been really.
So. Did you? Oh, that's, it's. I did a spot here of like across this. What I about the calendar. Oh, yeah, oh, yeah. I cover it 30 minutes.
So you're running upstairs.
Dollars.
Not to you.
This is the place that we gotta get to.
Oh, that was there.
Love it too.
It's insane.
We gotta apply for it today. So.
Yeah.
I actually registered to. So I don't know.
Yeah, keep going on Tesla.
Oh, I'll
Send her out the
Just like.
So I get
In the next 3 weeks, and then you're,
Yeah.
you know.
I gotta thank this people. So like,
I cover Colorado.
everything.
Some places are like making everything.
It's very good.
I don't know.
Yeah, it's crazy that you guys don't know.
Oh, yeah.
Some places are like making.
For rare disease, the gene.
Like,
My friends on the property.
No, it's just text.
Yeah, exactly.
So I'm doing hides and EDD. Oh, yeah, this year. Yeah. Why? What's going on?
yeah,
Yep.
but.
We're doing things right now, but nothing yet happened with that, yeah.
Yeah, I had to put our.
Oh, for lunch. He's like, told you, like, nobody can say that. I think he's like an hour.
Yes.
They're doing.
So,
Yeah.
yeah.
Really?
Yeah.
You're.
Yeah.
Oh, yeah.
So there's an answer right now.
It's also.
You know, I need to say, small cells changing, so they go right, like I think.
Oh, you
Yeah.
got it already. That's nice.
Yeah, that's.
It's an hour.
Good.
Sit it in.
Now, seeing it, yeah.
So we finished a little bit earlier.
This technically it's supposed to start at.
You'll say better.
Okay.
Right.
Yeah.
That's
Yeah,
what
we
me.
just, okay.
Yeah. Oh, okay. Tell Leah said hi. I've only texted them. I haven't talked to them. Oh, yeah, actually, we had a call Monday, but it was all weekend, so. Right now, we only have. But, it's not anything that's called.
Very much with a non-competitive, you guys for a long time, but now it is.
My mom.
Names.
Yeah. Yeah, you can just sense we're probably gonna.
She said, you don't get a table, and I said, "No, here you-" Oh, and she's like, no, I mean, I have a table for the various space jamming is next week, and I'm like, well, who's coming today? Cause it sounded like in her text, like, there's three, everybody just wrote it out.
Right now.
Somebody was gonna take today, she was taking breast, and then I guess he was the last one. She's like, I have no idea. I was like,
We
okay,
might.
well, so I'm sure. Nobody's gone.
So just fine. We're in the test. You guys think we're looking at it? What's that doing?
How's the deuce?
Let's give something like stage 3.
I mean, that's what I did. And if you go to the last one, you guys,
I think that.
it's easy. You should just go to that one. Just check in, give my name and grab my match. She's like, I'll do it. So, but I'll see you, I guess, 2 weeks. Not even. Oh, check. Have fun. See you later. I wish you for my job. Yeah, give me.
Okay. Yeah, I think they're. Something or place specific, was specific.
That's what it really is. That's not. That's not. Yeah,
Yeah. That's all I think.
Yeah. EGFR, and then I think recently it's we didn't have it, there's little China, so but we have a study in the West States. Just around. Visualize you.
We already had something. Two. But we have. So, maybe try that like. Kind of nice. So need to take care of three. I have a patient, I think we. We're not gonna. Now let's do this. We have to like put resources out.
Back on the hunt again.
Yeah. It's all the time. Yeah.
Yeah, I think we do.
I think it's all straight on.
Yeah, and then we also.
At this point,
Yeah, that's the one, the key maker.
so you're taking home.
Oh, okay,
I
great.
think we are. The 22nd.
Yeah, right. That's a big jump. I remember when I, guys,
Yeah. I think it's just,
It's a big jump.
Okay, Thursday. Congratulations.
Yeah, it's true. It's true.
Yeah, that is good.
Yeah.
Thank you.
They love each other. Really awesome.
That's crazy. I remember we just had to get up. We're actually.
I might have.
Yeah, I'll wait till.
We could work.
Don't have each other's back.
You guys didn't do it yet. I thought politics usually kind of happened like December, like January.
You clicked on these when you were speaking.
I have,
We used to do stuff with Nasser at IU.
Yes, I did. Yeah,
I
yeah.
was IU faculty for a long time.
Oh, you
now.
were?
The
Okay.
genetics program.
Okay, yeah.
And then you still have to kind of.
Yeah.
That's where like, I kind of like, the idea. To, like,
Oh,
yeah,
okay.
yeah.
Very cool.
I was a resident down at IU.
Yes, that's what it was. Okay.
So I did a lot of stuff. Yeah, so I.
I left in 2019. I go to AMD because of soda. We got to go because of I still think that.
That program too. So that's kind of like my. Variable, like,
It's nice, yeah. So it's funny when we started that, it was like a conference room in R3 or R2. We got communicated breakfast and we used to just hate people to show up.
Oh, really? Oh my God. Yeah.
That's awesome.
And I've haven't been there in a while. I've seen the room, like a whole center. That
Yes, yeah. I think we built that like.
Yeah.
Yes. I'm worried though, because like the new hospital by Methodist.
Yes, I've seen it.
I don't think they're gonna get as sweet an area.
Oh, probably not.
I feel like they cut some of the costs.
Yeah.
Yeah.
Yeah, I'm excited to see that new hospital. Cause I drive down to India, my trip there.
Oh,
So I drive down to India for once in a while, so I saw it at Christmas. They're moving, they're making,
Years out next year.
wow. Just crazy.
But I don't know. I know.
I mean, honestly,
Methodist and all this kind of stuff.
Yeah.
Like.
the impact.
It's just gonna move in, what I heard is they might sell it to maybe their baby, because Riley's right there. Or I do something also.
Wow.
But even that, they built that in 08, so I did my pharmacy residency in 08. So,
Wow. It's always changes.
yes.
I don't know.
Always changes.
It's a. Here, but I use it.
Yeah, well, I mean, if it was like 3 days, How can I get offline? I'd like to hear more about your
Yeah,
practice.
for sure.
By our governmental process.
First and all.
And then she said whatever. No. Yeah. Yeah. I even was I was talking with somebody about. So. Gonna keep it out. Especially he's gonna get like 3 screens, like I sat there and I said, I remember when
Yeah. It's at the Leahy Clinic. And she was like, it kind of is, I mean, it's the sort of, it's where the conceptual approach to the reality of change, you know. No, no. No, I totally agree. Talking about changes as then, you know, it's hard for you as a non-clinical source to be sort of fixing clinical aspects of cancer care. But it's just without having like Enoch. Go over to the. It's just tough. Yeah, you ever go to Jessica? I mean, you just think like, there are, you don't go to the conferences that place at the end. You need to, well, I mean, it's just not your trade, like, you don't need to see it. It's stuff like that, like, stick with like, the non-clinical. Yeah, I did a, oh, and remember, like, I hate something like that stuff, in incremental steps over a decade, I gotta go training, you know, I mean, it's med school. Yeah, it's med school, and then it's their internship. And even. So I could go to, and then you go to. Well, there's. I mean, the opportunity. Everyone, that's like it. We still made it time. For you guys to decisions. Effects part. Well, I tell you, just like without me, it's 3 months. Think about it the same, because I'm not as concerned with the sort of administration and process. I'm sure you get infusion class. We're concerned it's clinically, so which drugs are truly breaking, because you know they're like there was competition. There are I'm out kind of selling the science behind. However, that is too. But I do remember like the podcast. Health basically focusing in on how hospitals are sort of late to the game of figuring out how to get access to patients to infusions and late to the game, that off-site or whatever you call them, like non-hospital based infusions. Have been acquired by other companies to create that's exactly the infusion. That is accessible to patients. Hospital and the hospital-based infusion clinics right now trying to figure out how to catch up. Stephen was
yeah. Send you the.
Oh, thank you.
Yeah.
Oh, you know what? There's my in there.
Just like.
Yeah. Right, and that's gonna be market dependent.
That's, I go to check.
Yeah.
Yes.
Yeah, like.
Yeah, you ever come, I mean, I see, like, being in John's age, I was randomly. Oh, yeah.
You guys check.
Did you?
Should have said 5,000. Hospitals.
No, I'm gonna go this way. I wanted to.
It's a good question to have. Like, and you just talk.
Yes. Yes, like thought you said, like you think, so this type of testing. It's a job, and yeah, Alex.
Yeah, because it's got that medical.
Somebody.
Where is it?
So,
Well, it has to be.
I mean, that's to me.
Somewhere, it's somewhere. Oh, wait, actually, go ahead and say.
Which obviously you already are.
Can we try to find Laura? I'm not a PC person. So on top of me stumbling through this, I think she put this up for us.
Yes. Okay, so I'll give you my take on
Screen
sub-Q
stop.
IP.
Okay, yeah, because I saw that, okay.
This is a pharmacist
This
perspective,
will help.
so these are thinking about.
No.
This and it's sort of like, okay, if you were to give this to my pharmaceutical, say, hey, we're switching to sub-Q. This is what makes them do it. We have to think about this and that, blah, blah, blah. So, it's not.
We're just toying around with the audio to see if we can get to the point where we can actually have my presenter. The Zoom sounds good.
But like in the same, it's kind of a little bit. But you'll see what I mean,
It's
so.
like people choose
So-
what was back.
Okay,
The short of-
somebody wants to log in on
It is.
somewhere else,
It's a-
so that they can try it.
I'll do that.
Like, this is not necessarily. Not even just a pass. You know, it's like, there are going to be generics or next tradition. Agents. In order to keep their anything relevant, they have to have, they've got to slap a H in a long. Sure, or extended exposure, extended release. So, no, they have to innovate because
Yeah,
whether or not their innovation is needed,
And it is.
it's still
Somebody's,
innovation and the companies
Ceci,
want to
what
be
did she
seen.
check? She needs to talk on the something.
Oh,
Can you tell her?
Yeah.
So on and so forth. So that's number one. So in the end, I don't see the biggest changes would be, yes, there would be certainly some patient satisfaction benefit to the sub-Q. Because, you know, it's a shorter sit in the chair, and
You.
correct. So that's a
Oh, sure, muted.
because the only benefit is if you're on single agent. If you're requiring other drugs, yes, you still need the chair. And
You can go into one of the wellness.
And the
rooms.
All right, so I joined and then I just unmuted.
Well, I could hear you really
yeah.
loud. Yeah.
Oh, I definitely am in the room.
This is still gonna blast me. Hang on one second.
It hurts.
Okay,
Were you able to hear me when you were talking?
Hold on.
Well, it was loud, so I'm not sure, but I did.
You can go in the wellness room
is there a time saved for
and then unmute yourself.
a sub-Q?
The other end.
Right, because then you have like an echo. Yeah.
Not only that, she on the other end or he on the other end, then it was here. Then I don't know how to explain it, but it just doesn't, when they're presenting, then everybody in here won't be able to hear.
Okay, so I'm in a quiet spot. I'm gonna go ahead and mute, and I can kind of hear you guys. Hold on. So go ahead and talk, I'll mute.
You can unmute yourself. Were
Okay,
you me?
I can hear you good.
No, now you can hear me. I'm gonna mute yourself and then I'm gonna speak through the mic and tell me if you could hear me.
Okay,
Okay? You can unmute. Did you hear me?
I didn't hear you outside of when you said unmute.
Yep, that's what's happening.
Okay, all right.
The microphones, so how it is, it's these two ports. So I only have two microphones, right? Like these kind of microphones. And what happens is if I need this, then those stop working. So then on the Zoom, you cannot hear me anymore.
Right.
Right? So that's what the problem is. People in here, I get it. The speaker, if they're speaking like this or like this, they can't hear. I get it. It becomes annoying for the people that are here. I'm sorry, but that's just the way it is. It's just we don't have any more space on the mic, I'm assuming, like on the port system, I guess. That's how it was built. And so that's the problem. I'm assuming that is what the problem is.
Yeah, no, that's okay. I'm glad that we tested it so that I can better explain the
Yeah.
outcome of when we use the mics compared, like for our virtual participants and also our recordings.
Yeah,
Yeah, so we don't want to compromise that. So, and I also like that this gave us a chance to make sure that you can hear me in the room because Dr. Chen is virtual. So our next presenter is not going to be here physically.
perfect. So then who the Dr. Chen, probably everybody could hear them speak because it's gonna be really loud in here and it's gonna be loud and clear. Because we can hear you perfectly right now.
Like I could hear myself like down the hallway.
Okay, so let me know if you want me to lower the volume or keep the volume the way it is when you come in the room.
Once she starts speaking,
I'll
then
just
can we just make sure we know how to lower the volume?
lowering it right
Yeah.
here, okay? Don't touch anything else, just lower everything
Yeah.
here. Everything else you did was correct, that's why. Perfect. So Laura knows how to lower the volume down. So if it sounds really, really loud in here, she'll lower it. You know what I'm saying?
Okay, I was just gonna come back in.
Okay. So sorry, guys. I'm glad that worked out and we tested that out. Oh, yeah. Okay, sorry. We're like, okay, sorry. Okay, so Laura knows, then I'm just gonna teach you as well. Yeah. In case she has to go to the bathroom. If you have to lower the volume, say it's getting really obnoxiously loud here, this is the way to lower it. And just touch that to not. Otherwise, all the settings are gonna make.
It's kind of funny that someone have him on Zoom.
Oh, everyone you're talking about?
No, like the
Oh.
presenters should all be on Zoom.
Yeah. Well, if you're gonna do a Zoom room, it does make sense, like, because if this,
Because then their sound would come through.
yeah.
Like mine just came through.
Oh, you were loud and clear.
Do you know what I mean? You
Yeah.
should, like, I'm wondering if.
Oh,
But physically not have a presenter to present.
or no, like I think use like the audio from Zoom.
Like what I was just
Yeah.
doing.
Like virtually just use the boardroom, have them do it through there and like that. You're
Couldn't they
saying?
just be in here?
No.
Like,
Cause
like what if I
oh,
unmute right now? And just start talking.
That's gonna.
Okay.
So.
All right, well, at least we're
So,
trying all the
No,
options.
it does make sense. If you want the presenter to sit in the boardroom, I'll open up the boardroom and they can sit in there and present, but it's just really not nice. And it's not like,
No, what's the point of being
What-
here in person?
that's what I'm saying. It's not nice to have them sit in a different room.
No, we'll just make sure that we really reiterate. Yeah.
The system is great, but it doesn't work.
So I am not the only creative thinker in the room, you know, like, so they're like,
I know.
you know.
No, we get it. I think everybody was just like. But like, I'm so sorry. It just, I understand it's just annoyingness. What other people in the future have done is like, they just called an AV team. The AV team would sit in the standby right here and they would add, like, I don't know how they do it because I'm not AV, like that type of AV, I'm not. They tap into her system, they add extra ports, and so they just lapel everybody. I don't know what the whole thing, I don't know what the cost of that would be, and I don't know how they do that. We're not there, like, as a building, we're not there yet, because we're not, so they're not gonna spend money on or AV on us.
They work?
That's the problem here.
They work.
No, so,
So they were right.
yes, no, so I went to the other room and I was speaking and it's very loud. It's gonna be funny what Dr. Chen is gonna be the loudest presenter today. Because she's coming through Zoom. So I said, what if we all use Zoom, but you get that feedback with the speakers? So when I was in that other room and Vijay was on the microphone, it's dead silent on Zoom. You can't hear anything.
What's happening is so the system only has 2 ports, right? So those are 2 microphones upstairs, like right there, you see like those green lights, those are microphones. So if I'm like talking, even like this low on the Zoom guy is able to hear it, but you guys are not able to hear it. I don't know why it's like that. It shouldn't be like that. It is. So if I say you have the Zoom going on, you're using those ports, and I turn this on, that means there's nothing for this to like communicate with because this is the 3rd port.
It was quiet in the other room on Zoom. Yeah, so it was kind of weird. But the funniest thing is that now Dr. Chen, who was our virtual presenter, you're gonna be able to hear her down the hallway.
Yeah.
Oh my God.
It's so loud.
She's on, like.
Well, because I just went to a different room and I could hear myself down the hallway.
Oh my God.
I'm like, should we just have everyone to go hide in the boardroom and present? We'll be able to hear her better, but then what's the point?
So the reason why you guys are able.
So I
to
already
hear
warned
her
Frank,
all
like,
the
speak
stuff.
up. We won't have a doctor or a problem with Dr.
I know.
Chen. It might be too loud. Like, we have to
Yeah.
learn how to actually lower it.
Yeah.
But then when Frank comes up, I'm like, you just project. And Bijal was just saying that you can have a third party AV company come in that can add some extra support, like whatever that they can utilize. But right now it's either microphone or Zoom can hear us.
Okay.
So we want Zoom, so we're just gonna have to
Yeah.
project.
Okay.
The other thing is, the reason why you're able to hear throughout is because I have it on overflow. Sitting outside taking calls. If you don't want that and you just want the volume in here, let me know now.
For Dr. Chen, I would say probably just in here, right?
And I'll take out the,
Not the presentations out there.
No.
Okay.
so I took out the overflow, so
Okay.
now you're only gonna hear it in here. Again, you wanna test it, just because like we've been having issues.
Okay, so
Yeah.
I think you can just hear me in there.
Yeah, we can
Yeah.
all hear
I'm
you.
here. It's so loud, I can hear myself. We're testing Zoom.
It's okay. It's not that loud. It's fine.
Yeah, it's
Yeah.
not out here. It must just be in the session room.
Yep, I took it off of overflow, so you could only hear it, in the room. Yeah. So you guys will only hear it here, you won't hear it outside,
Yeah.
okay?
Thank you so much.
No, you're welcome, I'm sorry.
I heard, but.
Yeah, because I took it off.
Oh.
So what was on before was overflow. Overflow allows you to hear the meeting all throughout the system.
Probably good in some cases.
Yeah, yeah, but I think you guys want to keep this one private.
Yeah.
Yeah.
Sorry, guys.
No, it's okay. Thank you
Oh,
for your
turn
time.
off my phone there.
Oh.
That would be great.
Speaking of phone, I don't know where mine is. That's when you don't wear pockets. I leave it like everywhere. Just place it down. Well, I'll come out there too. So we're good. You're good? Thank you for coming in. I know you're finally sitting down,
Sure.
getting a break.
So the next one is next week, right?
Yeah.
It's 80 years.
It's the same area, it's the same room.
Okay, glad that you can hear us.
Hello, can you hear me?
Yes, perfect. Okay, just wanted to check that everything is great.
Okay.
You have what up the slides.
Uh,
Either or. I think you're able to share the slides yourself if you would like.
yeah,
For you.
yeah, I will share because I made like a few changes. So then how is it going like this?
Okay, we can see them on Zoom.
Are you able to see my first slide?
Yeah, on the computer, we cannot be projected, so we're trying to fix that.
Let's see.
Oh no. Yeah, do you want maybe you can email us? You want because I think we cannot project from the computer to the big screen. Do you mind email us the new PowerPoint?
Oh, the new? Okay, all right,
Yeah.
yeah. Okay, so let me make sure it's working. So where is it?
Showing the screen directly.
Okay. You figured it out?
Yeah, I just changed it because before it was like an extended display. Now it's mirroring exactly what's on.
Okay, and can we make it? This is what Dr. Chen is sharing. So maybe
Yes.
So maybe Yolanda, can you? So we were able to project it. Do you want to? Because we can see. Can you make it as appearing on your side to be just full the PowerPoint? So we can see a window with your name. Okay, never mind.
We do a lot of GFR. I know you said that. It's,
Okay, we're all set. We can project it. You want to try it? Advance one slide. Make sure we can see that you're advancing.
Where are they? Are they presenting virtually?
Yeah.
Oh.
Just that one. Just that presentation. It was just a last minute change. Don't be disappointed. It's actually better acoustic.
Okay.
See? Do you want to advance one slide and then so that we can see if we can? You're trying to advance it? Can you hear us, Milana?
Hello?
Yeah.
Can you
Do you want? Yeah, just change one slide so then we move one slide so we can see if it works.
Oh, okay. Let's see. Okay. Yeah.
Okay. Works. Okay, perfect. You can go
Okay.
back. Okay, we're gonna start in a few minutes.
Okay.
Yeah, but no, it's just.
Okay. So thank you for coming back after that 1 hour, maybe 15 minutes of break. So the next presentation will be referred you to the last minute change. So will be Dr. Ilana Chen will present together sharing some slides with Dr. James Sika. They both are wonderful GI oncologists at University of Illinois at Chicago. Dr. Chen is our clinician scientist, she's focusing on GI cancer. Javi Torres is focusing more how the immunology and COVID is affecting cancer biology. So she's gonna talk to us today for colorectal cancer and circulating DNA and how this affects the management of early colon cancer. So thank you, Dr. Chen, for working with us with the change of the schedule. So you're ready whenever you want to start.
Yeah, so yeah, as you can see the title, so Dr. Jane had presented prior, but this I am using some of her slides and then I'm updating as of January 26th. Now I try to go down, it's not going down. Okay, so I have to use the mouse. Okay, so I don't have disclosures. So this was Dr. Jane's disclosures. And so I'm using the same roadmap that she had initiated. So I'm not like this time dwelling so much on the history. So what are like the relevant trials, what are the main trials, and what are their recent updates, and what are future directions and clinical utility. So I think by now most people have heard and are using ctDNA. So the ctDNA is circulating tumor DNA in the peripheral blood, that DNA that is released from cancer cells into the circulation. And so this was like, this is very old. So when I was in med school, I think they were already talking about it, but it was like purely like very confidential and not widely used, not used actually in the clinical setting, but people were already starting studying it. And so now it has made its way to the clinical setting where we routinely use it, even though there's still a lot of regulatory updates to be done. So we are starting using it for prognostication and predictive purposes, and sometimes we started using it for guiding the treatment. So some of the large studies, the most famous studies or the largest studies are the bespoke clinic the trial for colorectal cancer, and then the Galaxy trial, which is Japanese, and then there's also Dynamic, which is more the dynamic trials are more Australia based. So the bespoke trial is for colorectal cancer using ctDNA for the detection of minimal residual disease, and it's showing as a powerful prognostic and predictive tool in patients with stage 2 and 3 colorectal cancer. Similarly, Galaxy, part of a Circulate Japanese project, is using ctDNA in patients with stage 2 to 4 colorectal cancer, and is showing that the ctDNA is useful. It has similar showing in data that shows that prove that ctDNA is extremely useful in the clinical setting. And then there was a COBRA study which failed to demonstrate benefit. So it was terminated early. And then there's the dynamic group. So it had a rectal trial, which also sort of closed earlier than expected because the shift was moved to total neoadjuvant treatment. So like focusing on the bespoke, so it was the eligibility was patients who had colorectal cancer stage 2 and 3, and so the blood was collected, and for ctDNA that was measured by the Natera company, and so the physicians would receive the ctDNA result, and so at that time there was no like guidance of it was not like a randomized trial that would tell the clinician to do this or do that, but then it was to observe whether the physicians would be impacted in decision making on adjuvant treatment, and so patients would receive result, and there would be a discussion of the result with the physician, and so then there was also observation of whether the ctDNA would clear, and how many patients would receive adjuvant treatment, and patients who would have oligometastatic recurrence, how many of these would receive a surgery. So there was initially an intermediate analysis, and this was how many patients would be enrolled in stage 2, stage 3, how many would have detectable ctDNA, and then so that intermediate study did show that the ctDNA positivity during surveillance was prognostic of inferior disease-free survival, regardless of whether they would receive adjuvant chemo. And then ctDNA positivity was associated with the benefit of chemotherapy, was predictive of a benefit of chemotherapy, adjuvant chemotherapy. And then sustained ctDNA clearance was associated with superior disease-free survival compared with transient clearance or no clearance at all. And then the patient were appreciative of the use of ctDNA. So these are the curves showing that in ctDNA positive patients, the disease-free survival was was impacted, the adjuvant chemo would improve the disease-free survival. But on the right side, in the ctDNA negative patients, giving chemotherapy would not really do much. So the conclusion of this intermediate analysis was that at 2 year, the disease-free survival was superior in ctDNA negative patients, 92% versus 30% in ctDNA positive patients. And only the patients in ctDNA positive who would receive adjuvant chemo had a positive effect of the chemo. So there was an update at ASCO GI 25 and the final analysis, and that's confirmed what was said at the intermediate analysis. And then it confirmed that the benefit of adjuvant chemo was only observed in the ctDNA positive patients. And then importantly, the lead time, the median lead time for ctDNA positivity was 10 months over imaging changes. So the Galaxy trial, so that was a part of a large Japanese study called the Circulate Japan. So that the ctDNA was also using Signatera ctDNA. So the patients who were enrolled was stage 2, stage 3, and resectable stage 4. And so there was a observational stratification. And so there were the 4 cohorts that was ctDNA positive, and then patient receiving chemo and not receiving adjuvant chemo, and then ctDNA negative, receiving adjuvant chemo and not receiving adjuvant chemo. And then patients were stratified by stage. There was high risk stage 2. There was pathologic stage 3 and pathologic stage 4 who were candidate for tumor resection. And so basically similar to Bespoke, the positive ctDNA was predictive of the benefit of adjuvant chemo across all the stages. But in patients who are ctDNA negative, there was minimal benefit, or if any, there was actually not really observed benefit. So this slide is saying similar things. So going to the ESMO GI 25 update, so the data confirmed what was found in previous intermediate analysis. And so importantly, the patients who were ctDNA positive and who were monitored for ctDNA and found to be ctDNA positive, they were 3 times more likely to qualify for curative metastasis-directed therapy versus the patients who had the decision-making only on CEA monitoring. So CEA was the historical tumor marker that most people were using, blood tumor marker. So ctDNA, based on ctDNA, more patients were found to be qualified for curative metastatic directed therapies, which could be metastasectomy or radiation therapy based. And then, so there was other derived studies from the Galaxy study. So in pathological T1 disease, the ctDNA was predictive in 100%. So there was a gray zone where T1 patients we don't know can they have organ preservation or not. And then the ctDNA did help in the sense that every patient with negative ctDNA after local excision, they were found to be free of lymph node metastasis. So the ctDNA was helping to identify candidates, will help identify candidates for organ preservation. And so this is another benefit of ctDNA that we can predict. So now there was another analysis that the Galaxy investigators found is, so when a patient has post-operative complications, so there's a, the ctDNA measurement can be modified. And with complication, the ctDNA values were found to be higher, 9.2 nanogram per ml versus patients who did not have complications. And the reason, so that was when the ctDNA was measured pretty early after surgery, 2 to 4 weeks after surgery, the ctDNA levels were higher, and this is thought to be caused by systemic inflammation and tissue trauma. So the implication is that in patients who have grade 2 perioperative complication, the suggestion is to delay the ctDNA testing at least 4 weeks post-operatively. So that's another a recommendation that they have now from these findings. So the COBRA study, so this was the design that was for a stage 2A colon cancer. And then there were randomized to standard of care. Arm 1, standard of care. Arm 2 is assay directed. And then when the ctDNA was not detected, patients underwent active surveillance. When ctDNA was detected, they underwent adjuvant chemo, but then adjuvant chemo was not found to be more successful. So I'm, wondering if this could be. I mean, I'm not sure why in that study it was a negative result for the usefulness of ctDNA. It could be the method for ctDNA measurement. But I mean, it's worth noticing some of the studies might be negative. So the dynamic rectal study, as I had mentioned previously, that was for rectal cancer. So I'll go like past quickly because Dr. Jane had presented this previously, but there was a positive result for usefulness of ctDNA. However, there was a caveat: there was a small sample size. The reason is because it has to close early because a lot of people move to a different treatment scheme, which would involve total neoadjuvant treatment, where all the chemo is given pre-operatively instead of adjuvant post-op. So the dynamic study was also, so this Australian study was also studying stage 2 colon cancer and stage 3 colon cancer. So focusing on the stage 2 treatment. So the patients would receive, based on ctDNA positivity, they would receive adjuvant chemo, either CAPOX 3 months, FOLFOX 6 months, or monotherapy, 6 months. And so there were two two publications, one in New England Journal 2022 and one in Nature Medicine 2025 with a 5-year-old overall survival. And the outcome confirmed that using the ctDNA to decide whether the patient receives adjuvant chemo, using ctDNA would be non-inferior to using the previous standard of care. So that was a good result. So that was the Nature Medicine paper that was published last year, confirming that there was no that using ctDNA was non-inferior. So in the dynamic stage 2, so this is the details of the paper. So you see that patients were allocated to ctDNA guided management or standard of care, and then so you see that both curves, in blue, the ctDNA guided management, and in red, standard of care management. The curves are in this. You cannot distinguish the two curves, so that's that confirmed that ctDNA for stage 2, using the ctDNA for decision making on adjuvant chemo was as good as using previous standard of care. And so the tumor burden was also the ctDNA tumor burden and the ctDNA clearance was also predictive of survival. So they have a lot of so they have extended like ways of showing the data, and they also here in the center is the Kaplan-Meier estimate for specifically the deficient MMR tumors, and the log rank was not as great. And so now at ESMO, and also in a final Nature Medicine publication late last year, this team presented a study for stage 3, and now the results were not as great. For like overall for stage 3, the non-inferiority was not met. So looking at a subgroup of lower risk T1, T3, and N1, the de-escalation, there was indication that it might be safe, but this requires further studies. But overall, the study did not for stage 3 did not show that we could use ctDNA to de-escalate. So this is from the Nature Medicine paper from 2025. The standard of care is in blue, the ctDNA guided management is in red. So overall, the result is not in favor of the ctDNA guided management. So they have different ways of showing. So here, what is interesting, here in the center, this graph is showing that the higher the ctDNA value, the worse the outcome is for recurrence-free survival. And here, so this is basically saying the same message. And here, the conclusion is that with the de-escalation, they neverly missed the non-inferiority. And then they also dynamic for stage 3 study was also looking for escalation to FOLFOXIRI triplet in ctDNA positive, but the escalation wasn't result did not also show that intensification would benefit. So the also negative study for intensification with triplet FOLFOXIRI versus regular FOLFOX or CAPOX. So there are other studies that are ongoing and that were presented. For example, the Pegasus and is an Italian study. The Intercept is a MD Anderson study. So I have not seen that it was in a peer-reviewed journal yet. But all these, I mean, these studies also went in the sense of that ctDNA should be useful. So, and then the Array CRC is also an Italian study that is ongoing. They are also interrogating for escalation with FOLFOXIRI triplet. And then in the recent ASCO GI, the ASCO GI 26 just happened last week. So there was a poster that showed that a study that was actually presented at ESMO, but they did another analysis with central review, and so that was in patients who had a blood-only relapse positivation of ctDNA, and they would treat the patient with a Lonsurf. And so now with reclassification of cases with the central study, they did find that now using Lonsurf based on ctDNA would be useful. But it was only a poster. So, and I think it's hypothesis generating, and so I'm not sure it will come out as a peer reviewed. But I think it's more going to be the basis for a new study. So as a clinician, we have all these private companies. When I talk to the patient, I introduce ctDNA and I tell them we are sending it out to a private platform, private company platform. There's several companies. There's Natera, there's Tempus, and then other clinicians can use Foundation One. They can use Caris, Guardant. And so in the beginning, so we had the liquid biopsies, which were not patient-specific tumor informed. And then Natera was the more advanced, I think, in tumor-informed ctDNA. But then Tempus is also catching up, and the other companies are also catching up. So there is tumor-informed when the patient can provide enough sample for the company to inform the testing. And so the ctDNA will be based on the tumor mutation, specifically on the sample that we have available. And then there's tumor agnostic, but this is based on data that is not provided by the tumor, but the patient's tumor specifically, but on other data that is being collected from thousands of patients. And so why do we need to have a tumor agnostic testing is because sometimes the patient, we don't have enough tissue for making a tumor-informed assay. So there's more and more options. And so now I'm expecting that we'll have more and more options in the future. And then we'll have, we will be using, so we started using Natera, we start in recent years, and now I have started using Tempus, and then we're going to use Foundation, but I think other commissions are using other companies as well. So clinically, what I do, when I talk to the patient, like the shortcut I said, we have guidelines by which insurance base their reimbursement, and then some of the tests are covered in certain cases and some are not, and then not all of the societies are using the ctDNA in the algorithm for the insurance to cover the treatment. But based on the abundant literature, we feel pretty comfortable that this is useful for decision making. And then specifically for stage 3, I would not use the ctDNA negative to de-escalate therapy, but for early stage 2, this becomes more and more useful. And then I tell the patients that the ctDNA can detect a recurrence earlier than CEA or other blood tumor markers that we have been using for decades, or imaging that would be when the tumor shows on CT scan or PET-CT as a new nodule. And then in the near future, we would be like probably more confident as a regulatory instances start formally incorporating the ctDNA. So in the near future, when I talk to the patient, instead of saying this is still investigational in nature, I will say most likely that this is more established. So yeah, so the conclusion is, so ctDNA has proven that it's a powerful prognosticator for recurrence in colorectal cancer. The ideal timing is still being studied, and more data are needed. And I think the societies are still waiting for more data and studies to incorporate formally in the guidelines. And so Medicare has started covering certain cases, certain testing in certain cases. NCCN for colorectal, last time I checked a couple of days ago, it was not yet incorporated in NCCN guidelines. So basically, every time I think it's going to be incorporated, I cannot wait until it gets incorporated. But in past couple few days, it was still not incorporated. So that's why when I mentioned for the CME that I place the ctDNA still in the investigational category. So the question that Dr. Jane had is still the same question nowadays. So which of the following statement above the use of circulating tumor DNA in early stage colorectal is true? A, ctDNA is only useful for detecting metastasis in late stage. B, ctDNA can help predict recurrence and guide adjuvant therapy decisions in early stage colon cancer. C, ctDNA is ineffective in monitoring treatment response. D, ctDNA levels remain constant regardless of tumor burden or treatment. So the answer is B. ctDNA can help predict recurrence and guide adjuvant therapy decision in early stage colon cancer. So this is being incorporated in routine and standard of care. So it's not fully integrated, mostly I would say because NCCN had not integrated it. But I say it's being integrated because Medicare is already covering in certain cases. And then that was my slide, the last slide. So I don't know if you have any questions.
Thank you, Dr. Chen. We have 2 minutes for questions. So I'm just gonna go, if Dr. Chen, a little bit earlier than the early stage. Do you think that is it any study of having those patients with high risk for colon cancer, like the Lynch syndrome patients, any role of the circulating DNA for screening for development of colon cancer? So then maybe in the future those patients wanted that frequent colonoscopies, or hasn't been studied?
Yeah, I think, there are so many subgroups that would benefit from ctDNA testing. Um, yeah, because like Lynch patient or people with like genetic disorders that predispose them, they have to undergo invasive endoscopies every couple years, and it's very cumbersome, expensive, and risky because of the anesthesia risk. So I hopefully, they can have ctDNA help and then avoid maybe in the future. I think that's that would be a group that would have a huge benefit from having this testing ctDNA further developed and proven in their specifically condition.
Yeah. Okay, well, thank you so much.
Actually, I do have a.
Yes.
Sorry, this might not be very sciencey question, Dr. Chan, but you mentioned that the ctDNA is not part of the guidelines yet, but you still talk to your patients about it. How likely are they to take the test, even though it's not part of the guidelines?
So this is the thing is, so when I order it, there is a big like disclaimer that I have to check. So first I tell the patient it's a private company. It's not, the university doesn't do it. So be aware because, it's data that goes to a private company. I think only in once or twice the patients refused. And then I tell them the company is trying to get a reimbursement. So you might receive a letter from your insurance that the insurance refused to cover it. So far, when I have been ordering from Natera or Tempus, if the insurance company refused coverage, the test is still being done. And the patient hasn't been bothered by the company to pay. But I think there's like when I go on the on Natera website, I see like there's an option for patients who want the test to be done and they have to pay out of pocket. There is a like a phone number or link for them to. So most of the time, I would say more than 95% of the time when I request a ctDNA, it can be done, it can be technically done, it's technically feasible, then it's done. The only failure is when Natera or Tempus fails to do the test because of the sample quality.
Thank you.
Thank you, Dr. Chen. So our last session for today, thank you all for staying late in dark, is Dr. Weinberg, our lung oncologist at University of Illinois. Dr. Weinberg has his own lab of trying to find better biomarkers for leading the treatment for lung cancer. Today, he's going to talk to us about updates on molecular and treatment for non-small cell lung carcinoma. Thank you so much.
Perfect. Thank you, Dr. Maraca. It's always nice to be back and kind of give you the updates of lung cancer. So I'm gonna just disclaimer this. I normally focus on a few things and I don't try to overload. Today I'm gonna overload because I want to focus on 2025, and unfortunately or fortunately for lung cancer, we had a lot of approvals that we need to go over, right? And then I'm gonna focus a little bit at the end on 2026 and what are some of the things that I'm excited about for the next year. All right, so yes, we're gonna focus on molecular and translational advances, but more, this is gonna be updates in non-small cell lung cancer. Sorry, it's small cell lung cancer. I just didn't have time to hit on everything, okay? Can I advance? Oh, okay, there we go. All right, so where are we going? Where are we headed in 2026? And when I was starting to think about lung cancer in 2025, I started to think about all of these things now that you come across when you're streaming, where you can kind of choose your own adventure. Or maybe there are books now that are out, you can choose your own adventure, or you can choose your own ending. That's kind of how I look at non-small cell lung cancer in this day and age. You know, you have your patient in front of you, and you have to make a decision on what you're gonna do. Which adventure are we gonna follow for the patient, right? Could that be targeted therapy? Could that be immunotherapy? Could that be a clinical trial? So, you know, I kind of think of it now as choose your own adventure in non-small cell lung cancer. These are my financial disclosures. So I'll summarize kind of 2025. I'll talk about some of the approvals in non-small cell lung cancer today. And then we'll talk about some of the key 2026 readouts that I think are going to be potentially practice changing. All right, so non-small cell lung cancer care is really being reshaped, right? And that, as we're all aware of in the field, biomarker testing has now really become key to lung cancer, right? And I would argue, and you'll see me arguing that it shouldn't just be advanced stage anymore. All patients with lung cancer should really be tested with biomarker testing. And that's because we have more actionable subtypes. So we have more drugs that are good to put patients on drugs that are specific for their types of cancers. We know there are survival benefits from this. And a routine broad next generation sequencing panel should be sent, just like when we're thinking about working up a patient with a new diagnosis of lung cancer, a PET scan and an MRI brain, you should think also next generation sequencing. That has to be a standard of care modality that accompanies all of these patients, so that we can sequence safely the right drug, right patient at the right time with the right sequence, okay? Early stage systemic therapy, in the last year and a half has really evolved in the non-small cell space. So, we have neoadjuvant and adjuvant therapies now. Perioperative regimens were overall survival positive in 2025. So these are practice-changing things that we have to integrate into our clinic, right? And then there's a translational feedback loop that, Dr. Chen just talked nicely about in colorectal cancer in the GI space, but that's integrating into lung cancer. And what do I mean by that? I mean ctDNA really becoming a biomarker that's helping us in the lung cancer field decide who should get this therapy, who should be escalated, who should be de-escalated. So, stay tuned, because I think 2026 holds a lot in that realm as well. Okay, so molecular testing. Now, every time I talk about lung cancer, I have to talk about molecular testing. It's an education for everybody to know that you need to send testing. And what does tumor testing look like in lung cancer? It's not just DNA sequencing, okay? We also need to have a panel that has RNA sequencing. We need a panel that's going to have PD-L1 expression. We need other IHC modalities now, CMET, HER2. All of these things have to be assayed as potential biomarkers that will drive what therapies we choose for patients, right? So we have to make sure that a patient with new diagnosis of lung cancer is getting a comprehensive molecular test. So in 2026, I think there are kind of 3 lanes in the treatment developmental highway of non-small cell lung cancer. Obviously, the resectable space is going to continue to evolve, with perioperative options being overall survival positive. We're going to look at MRD and ctDNA in that lane. In the unresectable space, I'll talk about some of the intensification trials that are ongoing that I think are exciting, that we're going to see results from hopefully in 2026. And then in the metastatic space, molecular drivers are going to continue to evolve, but I think something that my colleague, Dr. Nguyen, and myself have been working on are, how to know when to escalate and de-escalate therapies and maintenance in patients, right? So that I think that is going to come to fruition potentially in the next year. All right, so I would say that, in 2024, when we're talking about biomarkers, we were like, okay, we've had the same biomarkers, we have these drugs for a while, we've got this. I think in 2025, things kind of evolved and we got a whole lot more approvals. So we need to hold on to our pathways. It's like a roller coaster, right? Okay, so I'm going to start with the big thing, 2025. And I think that's, the fact that in the early stage space, perioperative pembrolizumab, perioperative neoadjuvant nivolumab, both had results that read out that were overall survival positive. So there were 5-year update results from KEYNOTE-671, which was done in resectable stage 2 to 3B patients with lung cancer. And this was utilizing a perioperative approach, which was basically chemoimmunotherapy, followed by surgery, followed by more immunotherapy. And that led to a 5-year overall survival, about a 10% improvement in overall survival, which is significant, right? 64% versus 53%. Checkmate 816, 5-year survival also came out. This was a neoadjuvant trial, right? So this was a neoadjuvant approach where patients got chemoimmunotherapy followed by surgery, but there was no dedicated adjuvant treatment that was dictated by the study. So this was also positive overall survival. And if you look at the stage 3A patients, you'll see right there, nivolumab and chemo, 65%, okay? Overall survival at 60 months versus 53%. Now come over and look at the KEYNOTE-671 data. I know we're not supposed to compare studies to studies, right? But look, 5 years, 64.6% versus 53.6%. And that's with the addition of adjuvant immunotherapy. So what does that tell you? It tells me that certain patients probably don't need adjuvant therapy. Who are those patients? Well, that remains to be seen. Either way, neoadjuvant therapy in this space is a new standard of care, and that is what we need to be doing. Whether or not we add adjuvant on afterwards, or whether or not we choose to observe, we don't know what we should be doing, right? We need the biomarker. I think ctDNA potentially could play a role here, okay? So the bottom line is perioperative, it's really chemo IO, and I would kind of put an asterisk there. Neoadjuvant chemoimmunotherapy really is becoming the default for eligible resectable stage 2 to 3 patients without a dominant oncogenic driver, okay? So this has practical implications, okay? Obviously, multidisciplinary tumor board needs to be involved in all of this from the beginning because we have to determine who's resectable and who's not up front. We also need to be cognizant of the fact if we're going to give chemoimmunotherapy before surgery, we have to be aware of the side effects that immunotherapy can cause that can delay surgery and could potentially have effects on outcomes, right? We need to obviously send biomarker testing up front, right? If a patient has an EGFR and ALK mutation, we're probably not going to opt for an immunotherapy-based regimen up front. So therefore, we need to know who those patients are before we start treatment, right? So all patients with non-small cell lung cancer need to have biomarker testing. And then obviously the adjuvant question, who needs it and who doesn't? My hope is that in the next years, we're going to figure out that question. Probably, potentially, hopefully with ctDNA. All right. I do want to just mention that the NeoDora trial also read out, had initial results presented. And, this could be practice changing in the future. It's not yet approved, but I think it's something we need to pay attention to. So the NeoDora trial was basically resectable stage 2 to 3B non-small cell lung cancer with EGFR mutations. And they were randomized, these folks were randomized to receive chemotherapy or osimertinib and chemotherapy or osimertinib alone, taken to surgery after 3 cycles or 9 weeks of treatment. And then basically there was an adjuvant investigator choice for treatment afterwards, with the primary outcomes really being major pathologic response and pathologic complete response. And so you can see just the initial data that was presented, there was an improvement in major pathologic response between chemotherapy, neoadjuvant chemotherapy, and osimertinib therapy in patients with early stage EGFR positive cancer. If you looked at the immature event-free survival data, you also look, and I'm looking kind of at the 2 slides before the numbers really decline, but you can see those blue lines, those are the osimertinib regimens. They're looking like they're doing better than the red line, which is the chemo alone. So potentially, the NeoDora, the osimertinib combinations or osimertinib alone is going to lead to improved event-free survival. And so this neoadjuvant approach that we were talking about kind of in an untargeted population might start to be implemented into an EGFR positive population as well. We have to build the molecular workflows, okay? Again, biomarker testing is central to this, and quick biomarker testing, because we need to know who is positive for EGFR so that we can put them on the right treatment pathway. Okay, so I mentioned a lot of this. I think the question is, chemo, is that needed with osimertinib? Can we do osimertinib alone, neoadjuvant setting? And then, waiting for the mature event-free survival and OS results, which hopefully will come out in the next year or 2, will really help us understand, is this regimen really something we should be thinking about? I think the answer is yes, but we'll wait to see. And I just want to talk a little bit about major pathologic response versus pathologic complete response in the solid space, because I think it's much different than how we think of it in the hematologic space. So if we think of, a solid tumor and treatment with a solid tumor and assessment after the treatment, potentially a neoadjuvant therapy, we know that a major pathological response is basically one in which there are at least or less than or equal to 10% viable tumor cells, right? With the pathologic complete response being no residual viable tumor cells. Now, both of these have prognostic values, and both of them are being utilized in the solid space as surrogate endpoints, right? But I think we have to be careful about where these 2 different endpoints can be employed. I think pathologic complete response makes a lot of sense in the immunotherapy setting, so in the non-targeted setting, because we know there we probably are with immunotherapy curing a certain proportion of patients up front. So could that pathologic complete response actually be those, if you achieve that, are those the patients that we're actually curing? That's the surrogate there, right? Major pathological response, there's still cancer left over. That's more important for downstaging of disease, which I would argue in the targeted space, that's probably more likely what we're doing with the neoadjuvant approach, right? We're probably not curing people with targeted therapy, right? But what we can do is we can at least downsize them, get these tumors smaller so that their surgical outcomes are more optimal, right? This is just a practical clinical checklist for early stage resectable non-small cell lung cancer. I'll just beat a dead horse, biomarkers up front, okay? That's what we need, and then everything follows. All right, I'm gonna switch over to the EGFR space with the metastatic EGFR space. So FLAURA2 confirmed overall survival benefit in 2025. That's osimertinib and chemotherapy versus osimertinib. And you can see here, you know, the median overall survival with the osimertinib and platinum pemetrexed, 47.5 months versus 37.6 months. So positive trial, certainly practice change for us in 2025. For many patients, osimertinib alone is probably no longer the default first-line option, right? But how to select the patients that are going to get osimertinib and chemotherapy versus just monotherapy? Well, certainly higher risk biology. So high tumor burden, visceral crisis, that's patients that I need to get control of real quickly. Chemotherapy might be, you know, advantageous there because it works quickly. Chemotolerability is the other side of things, right? We know renal, marrow reserve, neuropathy are all side effects that we have to take into account and consider patient comorbidities as we're thinking about giving chemotherapy to a patient. CNS disease, the patients with brain metastasis benefit more with osimertinib, which we know is active in the brain, but with that addition of chemo, do they do better? And then certainly the adjuvant or the maintenance plan, right? What do we do with pemetrexed? You know, do we continue pemetrexed with osimertinib once they get through those first 4 cycles of platinum pemetrexed? Do we stop it? How do we decide what to do in the maintenance setting? That's where I think ctDNA, de-escalation, escalation protocols come into place. All right, let's talk about the other big one, the Mariposa trial that was also positive and had overall survival results in 2025. So again, the Mariposa study took metastatic patients with EGFR mutant non-small cell lung cancer and randomized them to amivantamab, which is an EGFR MET bispecific antibody, along with lazertinib, which is a 3rd generation EGFR TKI, not unlike osimertinib. And so that was one arm. They also randomized to lazertinib alone and then also osimertinib. And so we read out the Ami-Laz arm versus the osimertinib arm, and this was a positive study. They didn't, median overall survival wasn't reached in the Ami-Laz arm. The osimertinib arm, it was 36.7 months. So certainly there are now these 2 osimertinib and chemo and amivantamab and lazertinib, both OS positive frontline regimens approved in EGFR positive cancer. It's going to be about personalization, about patient goals, about toxicity, tolerance, and the logistics of giving medications. I think that's how, you know, on the ground, we're integrating these regimens into practice. So higher grade, obviously, we have to think about all these things, right? Maybe one has different side effects than others, right? Mariposa, for example, if you compare it to osimertinib alone, there are more skin reactions, there are more thrombosis. There's also infusion reactions, although I will point out that it just got approval for subcutaneous formulation, and the infusion reactions are much reduced with the subcutaneous formulation. Still, requires proactive dermatologic prophylaxis. What I'll say about the side effects are, yes, there are some side effects that we need to address, but there are prophylactic regimens that are approved now and used and help to ensure that patients don't have to discontinue treatment because of one of these adverse side effects. So they're manageable. It's a shared decision-making visit with a patient whenever I'm talking about what we're going to do, and overall survival benefit versus obviously adverse event burden comes into play. And then the sequencing question is a big one. What do we do after dual inhibition, the Mariposa regimen versus the chemo osimertinib regimen, right? I think the sequencing is going to change. That has a lot to do with some of the other approvals that we had this year. So I've just summarized the three main frontline trials in metastatic EGFR positive lung cancer, and this is efficacy, right? And you can see here, so the gold standard is overall survival, osimertinib 38.6 months in the FLORA trial, right? We now have the FLORA-2 trial with osimertinib chemotherapy at 47.5 months. We now have the Mariposa study with AMI and LAS not reached, but we know it's probably at least that, if not more. We'll wait to see what the final results show. So there are three very efficacious treatments. And I think we can't forget about single agent osimertinib. Have that down at the bottom, right? In my patient population, that's still a real option for a lot of patients who are maybe elderly, more frail, which we see a lot of at University of Illinois. I think, that in terms of the two intense options, the osimertinib and platinum pemetrexed versus the amivantamab and the LAS, certainly have patients who come in and say, I don't want chemotherapy. And so this is, the AMI-LAS option is a non-chemotherapy option, right? At the same time, we'll have other patients that, might have rapidly progressive disease coming in, very symptomatic, and you need control right away. And so, that's potentially a benefit with adding the chemotherapy, the osimertinib. So these are things that we're going to have to deal with and think about in clinic as we see these patients and we have more and more options. Okay, so let's talk about the antibody drug conjugate wave that occurred in non-small cell lung cancer in 2025. Dato-DXd was approved for EGFR mutated non-small cell lung cancer. So the indication is really for advanced metastatic disease after prior EGFR directed therapy and platinum chemotherapy. And this was based on the TROPION-Lung01 study that randomized patients to Dato-DXd versus docetaxel. You can see the overall survival results, median overall survival, 15.6 months. This is in a very heavily pretreated population, okay? And historically in the second line, we usually think in the metastatic EGFR setting about 6 months overall survival. This is at 15.6. So this is pretty exciting and certainly practice changing. And the post-osimertinib space is certainly filling with a lot of ADCs, a lot of studies with ADCs, and this is going to certainly change our referral patterns. It's going to change our supportive care needs as each one of these ADCs kind of has specific side effects that we're going to have to manage. All right, so these are the clinical pearls that I just talked about. All right, CMET. Teliso-V also approved this year for patients with lung cancers with high CMET overexpression, right? And this was basically, these are patients who have been previously treated advanced non-squamous non-small cell lung cancer with high CMET protein overexpression. And this was based on the Luminosity trial. And from that first initial stage one, this was a phase 1/2 study. From that first phase 1, it was noted that really the people who were benefiting were the non-squamous EGFR wild type patients, and that was expanded. And this is the data from that study that shows basically in the green line, those patients with non-squamous EGFR wild type lung cancer that are c-Met high benefiting the most from the treatment with Teliso-V. So certainly this has broadened our biomarker thinking beyond just genomics, right? This is an IHC test that we have to get on top of PD-L1, on top of HER2. And we know now that in lung cancer, protein expression is actionable, right? And so we need, our panels can't just be genomic DNA, RNA panels. They have to also include protein now as well. Remember, this is not MET exon 14 skip mutations. This is totally different than that. So that's something that I teach the fellows all the time, very important. That's a totally different targetable mutation that we have different drugs for. So we're not talking about that when I'm talking about c-Met overexpression. All right, so talking more about the targeted space. So ROS1, which is a fusion that we see less than 5% of lung cancers will have it, but certainly an area where we've gotten more and more agents. So taletrectinib was another one, a new added targeted option that was approved this year. And if I just compare all of the 4 approved ROS1 inhibitors right now, you know, we kind of look at them in terms of the dose. Well, they're all oral, which is really nice for patients. And they're all once or twice a day, really nice for patients, right? What are the adverse events? Well, they're not all equal when it comes to the side effects that we see with these agents. And most notably, taletrectinib, you know, has GI side effects, right? Which we didn't see as much of in the other agents, right? But the good news is that most of these GI side effects were grade 1. So that's usually manageable, especially us as oncologists. We usually are pretty good at managing grade 1 diarrhea or grade 1 transaminitis, okay? But if you look at the median progression-free survival in TKI naive patients, we're not, again, supposed to compare, it's supposed to be apples to oranges sort of thing, but we do it. And we see that, you know, potentially could the taletrectinib be working a little bit better in terms of efficacy? Maybe, right? So certainly how I pick or how I would pick is based on the patient that I'm seeing in front of me, the comorbidities the patient's having, and obviously the side effect profile. And if I think this patient, you know, is diarrhea going to be better than, you know, dizziness for the CNS side effect for a patient, right? So, and knowing that I can also potentially sequence change regimens if they're, you know, one patient does have, you know, an adverse reaction. Could I try a different drug? Yes, it's nice to have options. Okay, so that's kind of what I'm saying. Clinical impact is more competition in the ROS1 space, but better sequencing choices, and certainly a higher need for those discussions about toxicity and CNS penetration. Okay, we'll turn to the exon 20 insertion space, which also had a year. You know, this is kind of now what I have in this chart is sort of the different lines of therapy. Here we go. All right. That are.
This is the definition you're crashing it.
What's that?
This is the definition of you're crashing it. But it's session.
Until that will be fixed, do you, for the EGFR mutant patients,
For
when they're progressing on osimertinib, do you switch them to Mariposa schema?
That's a very good question. Wait, have I switched them to the Mariposa regimen? I haven't, but I have added Mariposa 2 regimen, which is amivantamab plus chemotherapy.
Just turn off the Google. Gotcha.
Something maybe not, yeah, like.
Feel like I touched it. Oh, I just blocked it. Maybe I'm blocking it. All right. Gotcha. Try not to move. Yeah. Good. All right. It's getting tired. So exon 20 insertion. So this is a very rare population of patients. I've seen only probably 2 or 3 in the 10 years that I practice, but it's nice to have options for these patients when they do present, right? And so here I've kind of laid out where we're at in the metastatic space with these patients. So really the frontline option that's approved is carboplatin, pemetrexed, and our friend amivantamab, which we talked about earlier for other EGFR mutations. And that's a first line option, but what to do in the second line option? So previously, amivantamab monotherapy is approved if they haven't gotten that in the first line setting. And then more recently, we had the approval this year of sunvozertinib, which is approved in the second line post-platinum setting. It's an oral agent, which is really nice. And that's another option for a patient in the second line setting. And then in the third line setting, potentially we have post-targeted therapy and chemotherapy. That Dato-DX that I talked about also was efficacious in other EGFR mutations, not just the classical EGFR mutations that I presented the data for from the Tropian study. Sunvozertinib is interesting. It binds to exon 20 insertions are interesting. Basically, it's a mutation that pulls that ATP and basically keeps the EGFR molecule active, right? And that leads to all the bad stuff that happens downstream in terms of tumor proliferation and survival. Sunvozertinib is an irreversible EGFR inhibitor that binds to that pocket and basically inhibits further downstream signaling. And then just looking at kind of safety and tolerability of these agents that now are available in this space. Amivantamab, we talked about the safety and data. There's mandatory prophylaxis that comes into play, especially for the dermatologic AEs with amivantamab, with sunvozertinib. There's hepatotoxicity, which is the big thing that's been reported with this medication. And Dato-DX, the big things, obviously nausea, alopecia, stomatitis, but the big thing is the ILD pneumonitis, which we want to be very cognizant of. So, we have this evolving landscape in exon 20 insertions. I'll just end, I think I go on to 2026 next, but this is sort of the space in HER2 mutated cancers, which is very interesting. We got 2 approvals this year, one with zongertinib and another one with cevabertinib, based on the BEAMIAN Lung 1 study and the SOHO 1 study. And you can see here, looking at efficacy and median progression-free survival, these were agents that are showing benefit in this space. Previously we had an IV formulation. This is nice because these are oral. So it's nice, and this frontline studies for these patients. So this is, going to change the space as well. Diarrhea and GI toxicity are the big things that we encounter with these medications. All right, so hold on to your slides. We're going into 2026. Okay, so stage 3. I think the unresectable stage 3 space may change this year. We'll see. But the Pacific 9 study is coming out. Now, what is the Pacific 9? Well, we have to go back to Pacific, okay, which many of you are familiar with. Pacific basically led to the approval of durvalumab consolidation in the unresectable stage 3 space after patients receive chemo radiation, which is the standard of care. Okay, so this approval has been around since 2018. We've been doing it. We've increased the overall survival by about 10%. That's great. Look at that. But we're still at 42% of patients alive at 60 months. There's still 60% of patients that aren't progressing or not doing well, right? So the thought was, do we need to do something more to that durvalumab? Add something to it to get better benefit, to get more survivors, more wins, right? And so the COAST study was implemented with durvalumab versus durvalumab and oleclumab, which is an anti-CD73 inhibitor, and then monalizumab, which is an anti-NKG2A inhibitor. These are both immunologic inhibitors, right? So the thought is that they're going to synergize with PD-L1 and checkpoint blockade inhibition to make the tumor more immunogenic, okay? And lo and behold, when the initial studies from the COAST study came out, we were seeing progression-free survival benefit and whatnot. This led to this Pacific-9 study, which is a phase 3 randomized control study. Basically, patients with unresectable stage 3 non-small cell lung cancer get definitive chemoradiation, and that's followed by randomization to durvalumab and oleclumab, and then also durvalumab monalizumab, and then durvalumab alone. And we'll see, primary endpoint is progression-free survival. It's expected to read out sometime maybe this year or next. So we have to be we have to be aware of this. We have to have our clinics ready to go. We have to understand the toxicities that are going to come from dual sort of immunologic blockade. Certainly, we need to see if the intensification approach actually works. Could ctDNA be incorporated here to kind of help guide who should be intensified and who shouldn't? That gets to the subgroup benefit. Who is going to benefit from this? PD-L1 status, smoking, immune phenotype. The immune toxicity signals, pneumonitis, hepatitis, we have to look to see, are these all things that are manageable? We do a dual sort of maintenance approach. All right. I think perioperative personalization is going to come to fruition this year at some point. MRD, ctDNA, you saw it in the colon space, right? It's going to be at some point implemented into the lung space as well, because we see very similar data benefit with ctDNA monitoring. Right now, I think, the way that I'm thinking about it is ctDNA is really going to become sort of central to our risk stratification. And that's going to basically correspond to whether or not we escalate or de-escalate a patient, whether it be in the early stage setting, whether it be in a maintenance setting, whether it be in the advanced stage setting. All right, targeted therapy also is going to evolve, I think, in 2026, certainly EGFR after osimertinib. There are 4th generation TKIs that are coming out. Certainly one of the big issues with osimertinib resistance is the development of C797S resistant mutations. So these molecules are being developed like BLU-945 to kind of target those resistant mutations. KRAS, I think this might be the year where we're seeing evolution outside of G12C inhibitors. So talking about selective inhibitors for G12D and V, combination strategies, and then integration of co-mutational status. I'm already doing this in clinic with, sort of co-mutations and understanding how the co-mutations might affect efficacy to the treatments that I'm giving. And I can use subgroup analysis to further kind of tailor treatments. Is this the year that we get even more tailored in that respect? So BLU-945, just very quickly, there were some early results with the Symphony trial that's ongoing. Basically a 48% tumor shrinkage. So stay tuned. This is emerging data, but it looks very good. And then targeting KRAS G12D and G12V, there's a Mirati compound, I think it's BMS now, that owns this compound, which is specific for KRAS G12D. There's a Revolution Medicine compound as well. So stay tuned for the results there. I'm really excited about the pan-RAS inhibitors. How well do those actually work throughout all of the co-mutations? We know we have our own internal data that's showing that these mutations are not all equal in terms of who has them, in terms of how they respond to things. So does a pan-RAS inhibitor, is that going to be something that we can apply broadly? Or are there going to be, again, certain patients that are going to benefit from a pan-RAS inhibitor and others that may not? So profiling, I think biomarker testing. All right, so, and I think finally, ADCs are going to start moving to the earlier space as well, okay? This is just one example. The Tropion-Lung12 trial is ongoing. It's in very early stage patients, stage 1 non-small cell lung cancer, who potentially have a high risk of recurrence. And they basically get randomized to receive Dato-DXd, which we talked about, and then a PD-1 TIGIT bispecific compound versus standard of care therapy. So, we'll wait to see what that kind of data shows, in a stage 1, very early stage population of patients. And then I'm just going to summarize real quickly, 2025 practice-changing events. Basically, perioperative therapy is OS positive, and more specifically, neoadjuvant therapy is OS positive. So that really is practice-changing. We need to do that for patients with resectable, non-targetable lung cancer. EGFR first line, probably not monotherapy by default. I'm not saying we're getting rid of monotherapy, but we need to have a more nuanced discussion with our patients now that we have 2 different regimens that are approved in the front line, and we need to understand who we're going to intensify treatment on. Targeted and ADC approvals exploding. Obviously, we need biomarker testing. In 2026, again, remember intensification. So I think a lot of trials, it's not just the Pacific 9, that's maybe one that's closest to reading out. We'll have, other trials that come out that are talking about intensification for certain patients. How we're integrating biomarkers like ctDNA into those trials will be very important, right? Next generation targets and ADCs, I just showed you, I think, stay tuned. So now let's look at our choose your own adventure in 2026. I think it's just going to be, we're going to have more endings that we can choose from, right? Depending on what our biomarker status looks like, okay? So we have to choose wisely and we have to hope for a happy ending here, okay? And so I'll just thank everybody and I'll really thank AI because that's really helped me improve my artistic slides. Thank you very much.
Questions? Tell us which AI you're using. When warn us about your slides and I'm very impressed.
I say names and I came up with an idea of the choosing your own adventure, and AI was able to make it what I want. The choosing your own adventure, I thought that's what we're doing now, can make something like that.
They gave you a clear picture with not
I said, I want a clear picture. I want it to be a book that you can choose the ending. Did it. Use AI. AI can be your friend. I came up with the idea. I would never have been able to make that generate. So, you gotta use your tools.
Thank you.
Yeah.
One question. How do you think about second line EGFR sequencing now that chemo is moving up to the first line? How does that kind of impact? I know we're still biopsying, we're still looking for resistance mutations, but I feel like we've solved one. We pushed chemo a lot sooner, but now it's a little bit more challenging second line.
I think that's a great question. I don't have an answer. I mean, I think Dato-DXd in this population then becomes, you can use it if it's indicated, right? So that's a nice option. Certainly some of the, if you have a resistance mutation, now what are the resistance mutations that are going to develop from amivantamab and lazertinib, right? I think there's some data that the company has that actually shows kind of what are those resistance mutations. That would probably be, if I had a clinical trial for somebody who developed one of those mutations on LAS, that would be something that I would be considering very, very highly. But you're right, this space, I feel like it's like we're always going to be, because we're at the end of the day, we need to understand who we're actually curing. It's actually probably not a lot of patients in the EGFR space, right? We're making this a chronic disease, which is great, but we really need to get to the lab and look at who are the people who have been cured in the stage 4 space and what are the markers there? Because that's the way to understand. Otherwise, we know it's gonna be resistance mechanism after resistance mechanism. And this is already, I would say, a chronic disease for patients, which is great. But, at some point, being on something for 10, 15 years with toxicity, be nice to be able to cure these patients. So.
Nice to see in the brain mets era with the EGFR mutation. I think we're way behind on the ALK inhibition.
We are, except ALK is crazy because, if you look at some of the data that came, the LINA trial, for example, which looked at patients with earlier stage resectable ALK positive disease, they just got, I think, 2 years of alectinib. And the line is flat. That is the only Kaplan-Meier curve that I've seen in the targeted space where there's a flat line. Maybe it's going to come down. Maybe it's just we're really preventing, it got me to think, could we potentially be curing folks with targeted therapy? That's the only study that's ever gotten me to think that in the targeted space, because all the other ones, if you follow them through, eventually the line bottoms out, right? But that one is straight at 60 months. It was still, I don't know, close to 98%. That's nuts, so I think it's nuanced. It depends probably on the marker, and certainly brain metastasis. I think a lot of the problem with EGFR is a lot of the studies, they actually probably have micrometastatic disease when we start. So that's, if we could somehow figure out who has micrometastatic disease and not parse those out, is that the population of patients that actually were the ones without the micrometastasis in the brain? Are those the patients that just are basically close to being cured with their treatments, right? So I do think that we need to understand better or really early stage CNS metastasis.
So a question about screening. So because of all the work you guys have done on low-dose CT and all the work you've done developing the molecular tumor board, how far are we from a liquid biopsy for lung cancer as a screening tool? What we like?
Well,
or have you guys even considered starting to try to think about implementing that in some high-risk population? Like you're now getting annual low-dose CT screens, but we're going to add a liquid biopsy for lung cancer.
Yeah, I think, Delphi and some other companies have, these MSET assays that are being developed not only in breast, but also in lung. I think for me, the interest for me is not just in the genomic landscape, but understanding the immune environment that allows the cancer to develop. And so a lot of our work and how we get at that is, we're integrating at UIC, we're integrating now with our lung cancer screening program, AI algorithm. We're using a tool called Sybil to basically help us we're getting Sybil scores on patients who are getting low dose CTs. And I think potentially that score could help stratify our patients and we're collecting blood at the same time, right? And in my lab, we have some early markers, immune metabolic markers that suggest potentially this might be a patient that either could develop lung cancer or might have a very, very early lung cancer. So, you know, I think that's probably where the field needs to evolve to, because the detection of a genomic alteration early for ctDNA, that means you already have it, right? And so the goal for us at UIC is to prevent it, right? That's what screening is really supposed to lead to, prevention, right? I mean, people don't talk about that dirty word.
Yeah.
But, you know, that's what it is. And so I think, you know, we don't have a lot of preventative studies. And so that's where I think hopefully we'll evolve to. I know others are interested in this space too, but what are sort of the biomarkers that we could use? And could AI help us kind of figure out who are the patients before they even have any cancer that we could give something to and prevent lung cancer from ever even starting? I don't know. That's the long-term goal.
Yeah.
Thank you, everyone. I learned a lot. Thank you.